Hi guys, hope you're doing great. Good to see all of you. In my opinion, for any exam, one of the most important
Hi guys,
things,
hope you're doing great. Good to see.
one of the most important things that would be required is clarity of thought, and that is the objective of this discussion. Because when it comes to medicine, students get confused between a couple of options, and what I'll try to do is try to simplify the clinical algorithms. This session is not for any rote learning or not any ratification, but what we'll try to do is learn some concepts and then we'll try to deploy them, because what we're discussing are simplified clinical algorithms and clinical lifelines, I would say. Just let me know regarding the audio and the visual process whether it is perfectly fine, and we can get started with the current discussion. And my main focus will be to let you fine tune your reflexes. Every one liner will be still having those buzzwords. Like those buzzwords are like hypersonic missiles, right? That they are able to get to the target irrespective of whatever the opposition is doing. You can see, there have been so many examples in the recent couple of months where the hypersonic missile is so precise that it is going to hit the target. Similarly here, I'll try to teach you those concepts which are gonna help you get those questions right. Not some shortcuts, but at the same time very logical, rational, and I would say concept based information that helps you get to the right diagnosis. So I think we're good to go for today. And yep, I think we are having a lot of positive vibes at the moment. And let's get started with the very first question. This is a repeat of what has already been asked. So what you can see at the moment is, I'll just adjust the slide slightly. Low voltage ECG, and then there's a loud diastolic pericardial shudder. The X-ray is also shown, and even if the X-ray is not given, I know that you guys will be able to finally come to the conclusion, because what is present and is the key word for the first question for today is the word pericardial shudder. And pericardial shudder is always a feature that is seen in patients of constrictive pericarditis. So very good. I think everybody could pick up this calcification around the X-ray or the calcification around the inferolateral part of the heart of this patient. And at this moment, I also want to say that whether you are an FMG student or whether you are going to be sitting for NEET PG, just sit back tight for next 100 minutes, grab a paper and a pencil and try to learn these simple concepts, because a lot of questions, or not every question is going to be hi-fi, right? Some of those questions are going to be very simple and straightforward. So that is why we are doing this activity. And I think I had a very good input. The very first one for today is going to be that pericardial shudder is a feature that is seen in constrictive pericarditis. And well, how do I rule out cardiac tamponade? It is also having low voltage ECG, but there it will not be anything loud, right? There will be muffled heart sounds present. So that is a easy pickup anyway. And the second question that you can see, yes, Ayush, you're right, it is pericardial knock, it is called as shock, and it is also called as pericardial shudder as well. So great. Now let's look at the next information which is given, that is for low voltage ECG with the diastolic collapse of the ventricles. The key word here is the diastolic collapse of ventricles, which is an echocardiographic finding. And a lot of you have commented very rightly about that money bag appearance that is also present with like a very significant increased cardiothoracic ratio. So this will make the answer for this question as cardiac tamponade. And an additional point that I would like to just mention from the JVP perspective would be that both of these conditions will be having is a steep X descent, but then there's a fundamental difference when it comes to constrictive pericarditis. We will be having both the steep words coming up, that is a steep X and a steep Y. But when it comes to cardiac tamponade, there would be absent Y descent. So that is what is ultimately required. And the next question, that is the second one. Yep, absent Y descent is the better answer as compared to the blunting part for patients who are having cardiac tamponade, because rapid ventricular filling will be compromised because there's a squeezing of the heart from outside. Now, absent X descent and a steep Y descent. Yes, Ayush and Priyajit Dhar, they are spot on in their answers. Here, the question is not with respect to absent Y descent but is for an absent X descent, that would be for tricuspid regurgitation. And I had again very good answers, that would be CV wave. So the good thing is that you guys are doing super as far as the JVP waves are concerned. In fact, that table I think has been memorized very well, and it does help you in the actual exam also, because usually like one question on JVP will always be present. The easier ones are obviously that absent A wave and large A wave, but I thought I'll talk about those in the lower part of the table also, which I think are mentioned very, very correctly by majority of people. Let's move on to the third concept for today. In this third concept, there is presence of a narrow split second heart sound and bilateral crepitations in an alcoholic. You are all aware of the fact that alcoholic will be having his a deficiency of vitamin B1 thiamine, and therefore they would be wet beriberi, and therefore he has given you this information. There is presence of crepitations in a patient. There is a narrow split second heart sound. Both of these statements that I mentioned, bilateral crepitations means that there is pooling of blood in the lungs, and lungs are connected to left side of the heart, so that means there is left ventricle failure in a patient. So very easy question. I mean, he's simply asking that are you aware of the fact that lungs are connected to the left side of the heart? Even a biology student knows that, right? That lungs are connected to left side. I mean, obviously they're connected to left and right, but the input of the lungs goes to left, no, and if the left will fail, then there would be pulmonary edema. And even the auscultation finding, if you focused on, like I've emphasized it multiple times in your entire career, guys, every time you read the word narrow split second heart sound, always think of left ventricle failure. If he says ulta, that is a wide split second heart sound, then always think in terms of right ventricle failure. And anyway, this is not cor pulmonale, because cor pulmonale is caused by non-cardiogenic cause. So quick comments in the chat box. I want everybody watching the session to hit the comment box right now. What is the leading cause of cor pulmonale? Yes, guys, I'm waiting for your answers. And meanwhile, I'll be putting up another one-liner before you for in the form of acute cor pulmonale. You can do double entry in the chat box as well. Very good. I am having hypoxia, COPD, pulmonary artery hypertension. Yep, guys, your specific answer would be given as COPD only. That C for cor pulmonale and C for COPD, because yeah, your logic is right. Pulmonary artery hypertension because of hypoxia, but the disease that causes cor pulmonale is COPD. Yes, guys, hit the comment button now and let me know what is the cause for acute cor pulmonale. Very good, very good. Pulmonary artery hypertension and COPD is perfectly fine. Let's look at acute cor pulmonale, please. Yeah, coughs restrict right heart is a totally separate ball game, right? That's for small sign. Okay. Yep. Cause of acute cor pulmonale, guys. Very good, very good. John Darwin was the first one to answer that very correctly. That is gonna be pulmonary embolism. So do remember, one word will change your destiny and your career. If he says the word plain cor pulmonale, COPD. If he says acute cor pulmonale, pulmonary embolism. Let's move on to the next one, where he is mentioned regarding irregular pulse, absent A waves in a JVP. Yeah, it's a very characteristic question on atrial fibrillation, but it is having an except present. So what we are studying is complications that would be seen in patients of atrial fibrillation, because atrial fibrillation would be characterized by development of clots, and these clots can go out into the aorta, and from the aorta they can go in the brain. So you can be having is a stroke. They can go into the superior mesenteric artery or inferior mesenteric artery. So you could have is a mesenteric insufficiency and a gangrene of the intestine. And God forbid, if this clot goes into femoral artery or popliteal artery, you can have is a acute limb ischemia. But what you will not get in this case would be cor pulmonale. So what you need to do is, you can see the strike rate decreased a little bit. That's because the except word was missed there. Cor pulmonale is caused by COPD. Now, one way to solve the question is simply, cor pulmonale is caused by COPD. And the second way to solve the question is go by logic. The logic is the clots will go in the brain, in internal carotid artery, there would be stroke. If they go into superior mesenteric artery, inferior mesenteric artery, mesenteric ischemia. If they go in the popliteal artery, there would be acute limb ischemia in this patient. So these are like complications that are seen with atrial fibrillation, which is one of the commonest arrhythmias in clinical practice. Then we come to a named murmur. They love to ask, I don't know what fetish that they have for this in the FMGE exam for these murmurs, but they have asked about Austin Flint murmur, which is seen due to, yes, guys, quick comments. What is the cause for development of Austin Flint murmur? It would be a case of aortic regurgitation. And yep, it would be a severe aortic regurgitation, because there's a large amount of blood that is leaking back in the heart. So there would be a development of mid diastolic murmur. Very good. I think everybody got this right. Mid diastolic murmur. Whenever we read, there's a mnemonic for that also that I will mention at the moment. The mnemonic for mid diastolic murmur would be by the name of CAM, where alphabet C would be for Kericum's murmur. I think all of you know Kericum's murmur is a characteristic murmur of rheumatic valvulitis. When it comes to alphabet A, it's gonna be Ostenflint, which was asked in this question, and then it's gonna be the traditional mitral stenosis that has a mid-diastolic murmur with a pre-systolic accentuation. But here it doesn't matter for that pre-systolic accentuation. What matters is the word mid-diastolic murmur would be seen in CAM. That would be the mnemonic which is to be remembered. And let's now focus on young male with Kericum's murmur, which is a feature of what I've already told you, that it is a murmur, not a mitral stenosis, not a mitral regurgitation. It is a murmur of rheumatic mitral valvulitis. There would be Ashkoff nodules which would be causing damage. So the correct answer, or the one-liner to be remembered, is Kericum's murmur occurs due to, answer is rheumatic fever valvulitis. Obviously everybody knows it's rheumatic fever, right? But they'll make it much more technical. So it is a rheumatic fever valvulitis. Matlab ye hai ki the Ashkoff nodules would be causing inflammatory damage to the valve, and that is why there would be like development of leakage of blood from the LV to LA, and then this blood will move across back from the LA to LV. So actually Kericum's murmur is a flow murmur. Guys, Kericum's murmur is actually a flow murmur. That is why it's a diastolic murmur, because the maximum filling of blood in the ventricle occurs in the phase of diastole. Yes, yeah, water hammer pulse is a feature of aortic regurgitation. That's an easy question, doctor. Like, okay, that's coming up subsequently for aortic regurgitation. Okay. The next question is valvulitis. No. Valvulitis and MR are not same. That's the point to be understood. That Kericum's murmur is inflammation of the valve cuffs. It is long-standing mitral regurgitation that causes a systolic murmur. No, that is the point I'm trying to say. That when it comes to mitral regurgitation, it would be resulting in development of a pan-systolic murmur. That's totally a different ball game. That is because of damage to the chordae tendineae. Why do you get mitral regurgitation is because not because of valvulitis there, it is damage to the chordae tendineae, which are structures on the undersurface of the heart valves. They're damaged. So that is why like mitral regurgitation would be occurring. Let's move on to the next one. That is again a question of last time, Graham-Steele murmur. Graham-Steele murmur would be occurring because of Graham-Steele murmur would be a feature that is seen in patients of scleroderma. And why would this be present? So yep, guys, you can do a voting here, because otherwise it does not make sense. It is okay, so I'm having two answers, A versus B. That is what I want to see. Are you getting the concept right? Graham-Steele murmur is because of severe pulmonary artery hypertension. Guys, it's severe pulmonary artery hypertension causing a mild pulmonic regurgitation. Because Graham-Steele murmur तो early diastolic होता है ना, तो अर्ली डायस्टोलिक मर्मर को होने के लिए तो थोड़ा सा ब्लड लीक करना चाहिए. लिटिल बिट ऑफ ब्लड शुड बी लीकिंग, एंड फॉर लिटिल बिट ऑफ ब्लड टू लीक देयर वुड बी अ माइल्ड pulmonic regurgitation. So the correct answer for this is option number A. And you can see that here it is twisting of English words only, and that is what will happen in the exam also. So you need to get used to it. Graham-Steele murmur is a feature of severe pulmonary artery hypertension, and this severe pulmonary artery hypertension would then cause a mild pulmonic regurgitation. So get the words right. I'll just change my slide for Ostenflint murmur, which is seen with aortic regurgitation, where we get presence of that Corrigan's pulse and water hammer pulse. It is a severe aortic regurgitation again. So the severe word is coming up in both of them. It is severe aortic regurgitation and it is a severe pulmonary artery hypertension. So both words are to be remembered. The logic is that why you are having classical names for these murmurs is because of the severity of the disease process, and then ultimately there's a mild PR, thoda sa blood that is leaking across, and the thoda sa blood leaking across is responsible for that early diastolic murmur. And anti-SCL70 basically tells you that there is a connective tissue disorder by the name of scleroderma. The other name for the antibody is also anti-topoisomerase antibody, but that will do the antibody name subsequently. And okay, so let's move on to the next one. This boy is having poor school performance. There is a chorea and then there is a murmur present. Considering that there is a murmur also present and chorea also present, so two of the major Jones criteria are getting satisfied. And since the two major Jones criteria are getting satisfied in the question, that is why the answer for this question will turn out to be rheumatic fever. Huntington's chorea will occur in adults at 50 years of age, and Huntington's chorea will be having dementia also present. So there are 2 points against why the answer is not Huntington's chorea. That would be one, the age group would be 50 to 60. There would be dementia, there would be Parkinson disease like feature. And why this is not Wilson disease is because there is no mention of any liver damage. No, because Wilson disease needs to have liver and basal ganglia involvement, and here there is no mention of any liver damage that is given. And yep, the type of chorea that would be present in this case is called as Sydenham's chorea. What is present here is what is called as Sydenham's chorea. A question for you guys here. What is the cutoff for pulmonary artery hypertension? I mean, when do you say patient is having pulmonary artery hypertension? And when would you say severe? But before I ask you severe, I need to know whether you are aware of the fact that when you say pulmonary artery hypertension, mean pressure in the pulmonary artery normal is 15 millimeters of mercury. Pressure should be more than how much to call it pulmonary artery hypertension. Simple definition of pulmonary artery hypertension is what I'm asking from you. Hit the comment button, guys. Normal is 15. Definition would be more than 20 millimeter of mercury is defined as pulmonary artery hypertension, and if it goes beyond 60, then we say severe pulmonary artery hypertension. We do a cardiac catheterization. The cardiac catheterization would help us in diagnosis. The definition has been revised. If you're using chat GPT for searching for answers, it will give you all kind of answers. So my suggestion is don't use chat GPT for finding answers to questions. It is a prompt mechanism. I mean, I came across people who are saying they're using chat GPT for preparation. It's okay. I mean, it's a good tool, but then there are a lot of, because it searches from the internet, so it will give you multiple websites analysis condensed in a format. So it's a good tool, but then it should not be a primary source for preparation. Okay, what is the drug of choice for pulmonary artery hypertension? Quickly, guys. Drug of choice for pulmonary artery hypertension. Quick. Drug of choice for pulmonary artery hypertension is, yes. Very good. Bosentan and ambrisentan are molecules which would be used. Yeah, we should not be answering. First answer will not be sildenafil or tadalafil. The first answer would always be endothelin receptor antagonist. So this would be one of the main thing that we'll be using. Penicillamine in Wilson disease, yeah, it helps in removal of copper from the body, and that is why D-penicillamine is used for management, because it's used as a chelator, but then the main chelator that we use is going to be different. The chelator that we use is usually trientine. Okay, so Bosentan is a very good answer. Okay, moving to the next one. This girl is having joint pain, 25-year-old girl. And then the couple of other informations also given in this question, like a prolonged PR interval, a positive C-reactive protein. What would be the treatment that would be given in this case, considering age group of the patient and then informations which are provided simultaneously? Yes, guys, quickly. Inhaled nitric oxide test is a test for diagnosis of pulmonary artery hypertension, right? It's not the treatment. The main treatment for pulmonary hypertension would be bosentan with tadalafil, and along with that we add epoprostenol. That's called as triple therapy. Okay, so I'm getting a varied response in this case, guys. If you look at joint pain and positive C-reactive protein, you could think in terms of rheumatoid arthritis, but then considering a prolonged PR interval is also given in a question, so I need to think in terms of then rheumatic fever as my initial diagnosis, considering an Indian patient. So yes, I agree that you can think in terms of rheumatoid arthritis, but for rheumatoid arthritis, you need those antibodies, no? One of the antibodies that is always required for diagnosis of rheumatoid arthritis is anti-CCP antibody. Another one that is required is presence of RA factors. So I agree to the fact that rheumatoid arthritis is a very close differential diagnosis in this case, but then he is not specifying which joint pains. Like in this question, it's not mentioned PIP, MCP, and the wrist joint. So our first thought process would be to think in terms of rheumatic arthritis, and rheumatic arthritis would be managed with the help of best with aspirin. So the correct answer in this case would be given as option number A. But yes, this was a closely worded question, and what you need to pick up here is it mentioning that classical PIP, MCP, and early morning stiffness? Is it mentioning regarding RA factor or anti-CCP antibody? Otherwise, like if it just says arthralgia, joint pain, prolonged PR interval, considering an Indian setup, we should think in terms of rheumatic fever as our initial diagnosis. Moving to the next one, we are going to study regarding what is called as modified Duke's criteria, which would help you in remembering the features for diagnosis of infective endocarditis. This is again a question, I think this was last summer in the FMGE exam. He gave a case scenario like this. Yeah, rheumatic fever, arthritis is managed with the help of aspirin. Okay. Modified Duke's criteria, he says like how many criteria are being satisfied in this case. So criteria number one that is being satisfied is predisposition. The predisposition is IV drug user. The second feature that is present is presence of high grade fever. High grade fever, I mean, the two minor criteria satisfied: predisposition, presence of fever, and then there is a vascular phenomenon which is also given in this question, that is in the form of Janeway lesion. So when I count all these information, there would be a total of three things. There are no major criteria because blood culture is sterile, so that means major criteria is not there. Echocardiography is normal, so major criteria is not present. But the minor criteria that are present in this question would be total of three. So the correct answer for this would be option number C. You just need to revise those major and minor criteria quickly with me. The major ones would be mainly the blood culture aspects of 3 to 1 rule that I mentioned, and then is the echocardiography showing presence of agitations, and the minor ones would be predisposition, presence of fever, vascular phenomenon, and then you have immunological phenomenon. The immunological phenomenon is what I'm going to make you practice here quickly. The immunological features that are seen with rheumatic fever are remembered by mnemonic by the name of ROG. R would be standing for Roth spots, which is a fundus examination finding not given in this question. O would be for oscillor nodes. They're like P-shaped nodules in the tips of the fingers of the patient. And G would be for glomerulonephritis. So yes, this would be one of the important aspects that you need to remember for the information for rheumatic. And as far as that update is concerned, don't bother about it, guys. It's 3 to 1 standard information. Otherwise, it is 2 cultures that can be used at the similar time also. No, like earlier, it was like 3 cultures that are to be taken at 1 hour gap. Now he says there is no need for that. No, to prick the patient at different sites at a single time, you can take 2 sets of 2 cultures. That would be 2 and like there's no 1 hour gap now present. So I think that's pretty straightforward as far as like doing that process is concerned. And let's move on to the next one. Chemical cardioversion for ventricular tachycardia. The chap is suffered from a myocardial infarction. He says what is the drug that would be recommended for this? Ventricular tachycardia, considering that he has not mentioned any hemodynamic instability, we have to answer drugs. Otherwise, you know that whenever it is going to be PVT in a patient that is pulseless ventricular tachycardia, we have to go ahead with defibrillation for management of this patient. So yes, guys, I'm having answers varying between A versus B. So good, nobody's picking a flecainide. But for post-MI VT also, the drug of choice is to be remembered as amiodarone. It is not HASEC is a minor criteria. It is simply that HASEC per se is gonna be fastidious organisms. They are not usually available on routine culture. So any organism, if that is isolated on a blood culture, whether it is by serology or whether it is going to be diagnosed on the basis of blood culture, it would be still classified as a major criteria. So it does not matter. I mean, if organism is identified, whether it is HASEC or whether it is conventional organisms, in both the situations, your answer would be given as that it is a major criteria because bacteria have to be isolated on a blood culture. The correct answer for ventricular tachycardia would be amiodarone. Then for ST elevation MI, the classical ST elevation with a convexity, which is also called as a tombstone pattern, the first medical contact to device time should be kept under 90 minutes. But if he says like first medical contact to needle time, that the needle time of thrombolysis should be started within 30 minutes. Let me know your answers with respect to what is the treatment of choice of a high risk patient with non-ST elevation MI. I'm writing the treatment for ST elevation MI meanwhile. The treatment of choice for ST elevation MI is primary percutaneous coronary intervention. If it's a cath lab equipped hospital, if he specifies the word non-cath lab facility, I mean cath lab facility is not available, then we will be going ahead with management of this patient with fibrinolysis. So hit the comment button, guys. Tombstone pattern for Takotsubo, yeah, but the differentiation is Takotsubo coronary angiography is normal, na? In Takotsubo cardiomyopathy, the main differentiating factor in the question would be that coronary angiography is normal. And when you do a bedside echocardiography, the bedside echocardiography will be showing a bulge in the wall of the left ventricle, which looks like a head of an octopus. So that bulging of the wall of the heart as well as a coronary angiography normal will differentiate a Takotsubo cardiomyopathy from a myocardial infarction. Both will be having ST elevation, both will be having biomarkers that are positive. So what you need to look for in Takotsubo cardiomyopathy is the coronary angiography finding and the echocardiographic finding. Yes, guys, what is the treatment for non-ST elevation MI? Yeah, the treatment for non-ST elevation MI also is percutaneous coronary intervention. For both ST as well as in non-ST elevation MI, it is percutaneous coronary intervention that is used. And yeah, we use AB MON for non-ST elevation MI. That is the medical therapy. But here is asking treatment of choice now. So now you know that PCI is the treatment of choice for both ST as well as for non-ST elevation myocardial infarction. Yep. What is the treatment for calcified severe mitral stenosis? So mitral stenosis is back in business once again. The murmur that is present here is a mid-diastolic murmur with a pre-systolic accentuation. It is a low pitch murmur, so it is heard with the help of a bell. You need to turn the patient to the left side so that the heart comes closest to the chest wall, and you can hear this murmur in a lateral decubitus position. You can quickly, thrombolytics are not given for non-ST elevation MI. The reason why is because non-ST elevation MI is a platelet-rich clot. No, this is a platelet-rich clot, so thrombolysis is contraindicated. In ST elevation MI, it is gonna be a fibrin-rich clot, so that is why fibrinolysis can be used. But when it comes to ST elevation MI, fibrin-rich clot, so fibrinolysis is useful. In case it's a platelet-rich clot, then thrombolysis with streptokinase is a big no. We do not use thrombolysis. Very good. For patients who are having severe mitral stenosis, guys, we will go for balloon valvotomy. Here the answer is not valvuloplasty. It is valvotomy. The word is valvotomy. I'll just highlight this. The word that I've highlighted in the routine lectures also for severe calcified mitral stenosis is a percutaneous mitral balloon valvotomy. That would be PMBV. It is PMBV, guys. It is not valvuloplasty. It is valvotomy for mitral stenosis. And when will you answer valvuloplasty? Then I'll use a separate color and mark it here. That is for mitral regurgitation. If he says, how do you manage mitral regurgitation, which is causing symptoms in a patient? That is valve repair. We use, obviously the technology part is mitra clip that can be used, but at the moment I'm talking about traditional Indian way. So it is valvuloplasty that would be used. And for calcified, okay, it is a calcified severe mitral stenosis, guys. What you need to understand for this one, and a very, very good important hint is, because the question is mentioning calcified, so risk of stroke is very much present. So what we do in this patient is deploy in a prosthetic heart valve. What you need to do in this case is prosthetic heart valve is the best answer for management of this question. I'll rephrase what I said, because he's saying the word calcified, so risk of stroke would be very much present. If I remove the word calcified from the discussion, then my answer will become percutaneous mitral balloon valvotomy. But if it is gonna be a calcified severe mitral stenosis, a prosthetic valve is what is to be recommended. For a loud and a soft S1, all I can say is tachycardia. If there's any condition causing tachycardia, loud S1. If there's a bradycardia, there would be soft S1. And mitral stenosis is a loud S1 because the opening is narrow, no. So the pressure in the left atria is more, and the higher pressure in the left atria will cause a forcible opening of the valve. And because of the forcible opening, the elastic recoil will also be more. That is why loud S1 in case of mitral stenosis. Okay, so I think that this is sorted, guys. Prosthetic valve is what is recommended for management of calcified. If I remove the word calcified from the discussion, then it will become valvotomy, and if otherwise it would be mitral regurgitation. I can just quickly write down the data here because we had multiple inputs going on simultaneously. One I've told you MS, second I've told you MR, and then I have told you regarding calcified mitral stenosis. Everything that we're talking about is for severe manifestations only. So if it is severe mitral stenosis, the answer is percutaneous mitral balloon valvotomy. What we're talking about is for severe manifestations only, because otherwise we will manage the patient medically only. For mitral regurgitation, it is valvuloplasty, so that we can repair the damage. And if it is a severe calcified mitral stenosis, then we need to change the heart valve, because if we will try to deploy the balloon, then it's going to contribute to breakage, or the valve will break into pieces, like a biscuit will break into pieces, and that is like when stroke risk would be present in the case. Okay, moving to the next one, we have a acute coronary syndrome patient with ST segment depression and a T wave inversion, and there are normal cardiac biomarkers. So can I have a quick diagnosis in this particular case? Patient is having ST depression, so it cannot be ST elevation MI, and it cannot be non-ST elevation MI, because non-ST elevation MI cannot have a normal cardiac biomarkers. So because the cardiac biomarkers are normal in this case, the answer would be given as unstable angina. Very good. I think I had very good inputs there. And unstable angina is the differential diagnosis of non-ST elevation MI. The differentiation between the two is based on the values of biomarkers primarily. So the correct answer for question number 16 is unstable angina. Great. Let's move to the next one. Best biomarker for diagnosis of myocardial infarction. Yes, guys. You have a patient who's having severe chest pain, classical central chest pain, radiating to the left arm, going to the jaw, radiating to the shoulder. We will be doing is troponin levels. So it is a high sensitivity troponin I or troponin T that can be used for these patients. HS basically means that even minimal rise can be detected. So high sensitivity, troponin I and troponin T. But if he changes the question to reinfection after 72 hours, then we would be more comfortable changing our answer. Yes, guys, hit the comment button and let me know what is best for diagnosis of reinfection in a case of MI after 72 hours. Very good. Your answer would be given as creatinine phosphokinase MB, because CPK MB comes back to normal by 72 hours. So somebody has a heart attack again after 72 hours, CPK MB can be used for those particular patients. Then he says, what is first to rise in myocardial infarction? Yes, you can give quick comments here. First to rise in myocardial infarction. First biomarker to rise. Doesn't matter whether it is available in India or not. Just quick answers there. Last to rise would be L alphabet, that is lactate dehydrogenase, but he's asking regarding first biomarker to rise. Yep, your answer would be given as ischemia modified albumin. This would be rising by the very first hour. After 1 hour, your answer would be given as heart fatty acid binding protein. For any patient of a heart attack, if he says what is to be rising in the very first hour, then it is ischemia modified albumin, and after that would be heart fatty acid binding protein. Heart fatty acid binding protein would be between 1 to 3 hours, and in the very first hour it would be IMA, that is ischemia modified albumin. Do remember this small subtle fact, guys: ischemia modified albumin for the first hour and heart fatty acid binding protein for 1 to 3 hours. Let's move on to the next one. What is the ECG finding of acute pericarditis? Yes, hit the comment button. What is the ECG finding in acute pericarditis versus a pericardial effusion? You can be answering the two of them simultaneously as well. Yes, ST elevation. Your answer would be simple. It is ST elevation. Your technical answer would be it is a global ST segment elevation, in a sense that majority of leads will be having, because pericarditis is 360-degree around the heart of the patient, and along with this it would be concavity in upward direction. That concavity part, if you are remembering, it is okay, but you just need to remember acute pericarditis would present with chest pain. There would be pericardial friction rub present, which will persist in spite of breath holding, and in this patient there is a global ST segment elevation with a concavity upwards. But if he says what is the ECG finding of a pericardial effusion, because there's water outside the heart, so one of the easier ways to answer this would be water would contribute to a low voltage ECG, and second, because the heart would be dancing in a bag of fluid, so there would be a fluctuation in the voltage, there would be a fluctuation in the amplitude of the R wave, and this fluctuation in the amplitude of the R wave is what is called as electrical alternates. Between the two, if I have to select one, then it's a close call. Then I'll go by electrical alternates as something more representative for pericardial effusion. I can say it's like a heart dancing in a bag of fluid, so there would be variation in the amplitude of the R wave. Moving to the next one, there is a CSF lymphocytosis with low CSF sugar and elevated protein. In an Indian exam, every time they're gonna give you a question with the CSF lymphocytosis and there's going to be low sugar with elevated protein, you have to think in terms of tubercular meningitis. Obviously, what is also more important is the value of the protein. So usually the value of protein in this case would be given as more than 1 grams. Normally the amount of protein in the CSF would be like milligram, but here it would be coming in grams. And if it is going to be neutrophilia, that is neutrophils which are present with low sugar, then we have to think in terms of pyogenic meningitis. Please comment in the chat box what is the leading cause of bacterial meningitis in adult population. Can I have the name of the bacteria responsible for pyogenic meningitis? Yep, it is bacterial meningitis. Can I have the name of the bacteria, please? Yep, the most common bacteria responsible for this would be given as pneumococcus. The same bacteria responsible for development of community acquired pneumonia would cause a myogenic meningitis as well. Then he has asked regarding empirical management of pyogenic meningitis, which was asked last time. Whenever you read about pyogenic meningitis, it's going to be a combination of ceftriaxone and along with no, it is not pyogenes. No, it's not streptococcus pyogenes. It is streptococcus pneumoniae, right? Not pyogenes. I think that was a slight typo. It is ceftriaxone, and along with ceftriaxone, we'll be using vancomycin. The reason for rationale for using vancomycin is primarily because of the resistance that can be coming with ceftriaxone. So it's not because of any like staph aureus present. It is mainly because of ceftriaxone resistance. Empirical treatment of tubercular meningitis would be antitubercular treatment to be given, the standard 4 drugs along with for 6 months. And along with that, now for extrapulmonary TB, it is 1 year. So 880 for 1 year. And along with this, we'll also be using dexamethasone, that is steroids would be given for this patient. Empirical treatment for herpes simplex 1 encephalitis. This has a predilection to involve the temporal lobe. So the history will always mention amnesia because person will be losing his memory. Temporal lobe damage is usually seen with herpes simplex encephalitis. Loss of memory can be present. If he says what would be given for these patients, then yeah, you have to answer 880 plus dexamethasone. No, not plain 880. It is 880 for 1 year with dexamethasone for 6 weeks. For herpes simplex encephalitis, the empirical treatment would be to start the person on acyclovir. The PCR report might take 2 or 3 days to come, doesn't matter, but you can start the patient on acyclovir. And if it's gonna be cerebral malaria, then for these patients, most of the time he might give you that banana shaped gametocide or multiple ring stage on a peripheral smear. Then the drug that you'll be starting the patient would be on. Quick comments, guys. Cerebral malaria, please. Yep, artesunate would be the first line drug that would be started. You know that now it is resistant to quinine, so artesunate would be used. So usually they give those very straightforward questions on meningitis where you have to answer the empirical treatment for management of these patients. Okay, then comes CSF lymphocytosis with normal sugar and elevated protein. Yes, the interpretation, please, and then the subsequent treatment. There is a CSF lymphocytosis, but this is having a normal sugar. Therefore, the interpretation would be viral meningitis. Well, we really don't know which virus is causing it. So it is just supplementary, it is supportive treatment that would be given to this patient in the form of mannitol and conservative management that would be done. There's no specific antiviral treatment that would be given in this case. Moving to the next one, there is like low CSF sugar with elevated protein, and then he's also mentioning the patient is HIV positive. He has also mentioned positive mucicarmine staining. You can see the capsule around this organism. That pinkish thing is the capsule around the organism. So considering that this is going to be HIV positive patient, positive mucicarmine staining, this would be given as Cryptococcus neoformans. This would be cryptococcal meningitis. Cryptococcus neoformans is the organism which is responsible for this. Tell me the best test for diagnosis of Cryptococcus neoformans has been asked in your exam. Tell me the first test, best one for diagnosis of this condition. And the answer is obviously not India Inc. India Inc. and mucicarmine stains are always never very, we are not sure about diagnosis based on stains because the quality of stain can vary. The microbiologist might misinterpret it. So yeah, India Inc. is not used for diagnosis. I think this has been asked in the exam that for Cryptococcus neoformans, it is CSF ELISA for cryptococcal antigen. So I am writing the word CRAG. CRAG would mean cryptococcal antigen. And the second best way for diagnosis of this condition would be answered as yes, guys. After CSF ELISA for CRAG, can I have the second best answer that is to be given for Cryptococcal neoformans? The answer is not India Inc. That's one of the commonest mistake that people are doing. Numbers भी दे सकते हैं. They can give numbers also. Normal values I've explained to you. Normal CSF sugar is 2/3 of the CSF sugar, so values can be given in the question. Yes, very good. Lateral flow assay. It is either lattice agglutination or it is a lateral flow assay that would be useful for diagnosis of cryptococcal meningitis. Then would be albuminocytological dissociation. That is a feature where everything in the CSF would be normal. The only thing that would be increased would be proteins because we are talking about autoimmune condition. That would be Guillain-Barre syndrome. The organisms which are responsible for causing Guillain-Barre syndrome are Campylobacter jejuni. Let me complete the list. You guys can help me out. Tell me organisms causing Guillain-Barre syndrome apart from Campylobacter jejuni. Which virus causes Guillain-Barre syndrome has been reported from Gujarat. Yes, it is Zika virus. The second most important virus which is responsible for contributing to this is Zika virus, and then would be Hepatitis E virus. So there are three important triggers that have been asked for Guillain-Barre syndrome, Campylobacter jejuni, Zika, and Hepatitis E virus. And in all of them, there would be a demyelination of the spinal cord and demyelination of the peripheral nerves, and therefore there would be ascending symmetrical flaccid paralysis developing in a patient. It will start from the legs and will be going upwards. And when you do lumbar puncture in this patient, everything would be normal in the CSF except for proteins in these patients. Not Listeria monocytogenes. Listeria monocytogenes is mainly responsible for contributing to neonatal meningitis and even meningitis after 55 years of age. Okay, moving to the next one, we are having a patient who's having ptosis and arm weakness, and it is showing a diurnal variation. I mean, the characteristic words are ptosis, arm weakness in a male, and then he's showing a diurnal variation of improvement. And yes, guys, I'm waiting for answers. Everybody, quick answers there. The single fiber electromyography is the investigational choice for diagnosis of this disorder of the neuromuscular junction, and it is showing a incremental response. No, guys, you're not getting it right. If you are gonna be understanding incremental response, then you have to understand incremental response. एक होता है decremental response और एक होता है incremental और एक होता है decremental response. So decremental response is what you see with myasthenia gravis, but incremental response is something that would be seen for those cases who are suffering from very good Lambert-Eaton syndrome. Guys, you need to get understanding of this basic concept that question में सीधा myasthenia gravis मत बोल देना, देख लेना वहां पे डेक्रीमेंटल रिस्पांस दिया है या इंक्रीमेंटल रिस्पांस दिया है, क्योंकि यहाँ पर इंक्रीमेंटल रिस्पांस दिया हुआ है, इसलिए द आंसर फॉर दिस क्वेश्चन वुड बी गिवन एज लैम्बर्ट-ईटन सिंड्रोम. अगर ये डेक्रीमेंटल रिस्पांस होता तो फिर हम उसमें बोल दे देना कि भाई डेक्रीमेंटल रिस्पांस है तो कोई दिक्कत ही नहीं है. डेक्रीमेंटल रिस्पांस वुड बी अ फीचर दैट इज सीन विद myasthenia gravis. और एक और चीज देखो, myasthenia gravis में हमेशा क्या होता है कि जो सिम्टम्स होते हैं वो एट द एंड ऑफ द डे वर्सन हो जाते हैं, लेकिन यहाँ देखो क्या लिखा, इंप्रूवमेंट ना. So that improvement part will also help in evaluation. Hit the comment button और मुझे बताओ कि what is the treatment or choice for Lambert-Eaton syndrome. Quick answers, guys. Yes. Quick answers. Lambert-Eaton syndrome में दवाई क्या देंगे? 3,4-aminopyridine. Yes. The drug that we'll be using in this case is 3,4-aminopyridine. And उसके साथ में the second medicine that we'll be using in this patient is neostigmine. So there are two things which are to be remembered here that we can use pyridostigmine in fact. So but the main answer for this condition is 3,4-aminopyridine for management of patients of Lambert-Eaton syndrome. कौन से कैंसर के साथ associated होता है? Yes, guys, quickly. The answer is quick answers, guys. What is the cancer responsible or what's the tumor that is responsible? The Lambert-Eaton syndrome के लिए जो tumor responsible है, that would usually be lung cancer. It is oat cell cancer of the lung that would be responsible. Yes, guys. चलो, मेनली कंसेप्ट यही था कि हर क्वेश्चन जो टोसिस और वीकनेस पे आएगा उसको myasthenia gravis मत सोच लेना, थिंक इन टर्म्स ऑफ Lambert-Eaton syndrome also. मूविंग अहेड, एक और सवाल है इंक्रीमेंटल रिस्पांस पे. द क्वेश्चन इज रिगार्डिंग सिंगल फाइबर इलेक्ट्रोमायोग्राफी showing an incremental response, but this time it is a floppy infant. The history is that the child was given honey after birth and then honey was causing production of those honey was contaminated with botulinum spores, so there was a decrease in the level of acetylcholine at the neuromuscular junction. So therefore this would be answered by you. Yes, I think everybody has got now the correct answer for this, that is botulinism. Basically botulinum toxin is causing a prejunctional defect. So the common thing between the two defects that I mentioned before you at the moment is both of these 26 and 27, both of them are examples of prejunctional defects. These prejunctional defects would be having is a deficiency of acetylcholine, and because of this deficiency of acetylcholine, when we are going to do a repetitive stimulation, we get an incremental response. Jabki myasthenia gravis will always be having is a decremental response present. Yeah, snare protein is another important from the physiology perspective, that it binds with the snare protein and then contributes to prejunctional defect in a sense that it decreases the amount of acetylcholine release at the neuromuscular junction, and there would be descending paralysis. It would start from the face and then would go down. Floppy infant का मतलब यही है कि there would be cranial nerve palsy, like the child दूध पिलाएंगे तो नाक से बाहर आना शुरू हो जाएगा, gag reflex would be absent, cuff reflex would be present, cuff reflex would be absent. First cranial nerve palsy, then leg weakness or arm weakness would be occurring in a patient. Myasthenia gravis is prejunctional, is a defect of, myasthenia gravis is a post-junctional defect, but the two that I've explained to you are examples of prejunctional defects. Okay, moving to the next one, we are having this boy, he's having pseudo hypertrophy of the calf muscles. I mean, the calf muscles are looking big, like the calf muscles of football player, but this is like a pseudo hypertrophy. You touch the muscles, they're very flabby, and yeah, he's not asking you the diagnosis. He's saying what is the screening test for this condition. So the diagnosis in this condition is pretty straightforward. It is Duchene's muscular dystrophy. He's asking you the screening test here. So that's the statement to be remembered, the one-liner: screening test for Duchene's muscular dystrophy. Your answer would be given as CPK MM levels. Yes, it is CPK MM levels. So somebody just mentioned CPK. I just want to clarify it is CPK MM levels in this case. And now you can quickly comment on the investigational choice. I mentioned the screening test already, so I'll just write S for that. That the screening test is CPK MM, and now it's the investigational choice. Yes, guys. IOC for diagnosis. Yes, the investigational choice for this condition would be that we can either be doing a PCR for dystrophin gene. Yes, we can now do PCR not only for infections but for genes also. So PCR for dystrophin gene. Second best answer is what a couple of guys are mentioning now, that is muscle biopsy. And now let me know, what are you gonna do on that muscle biopsy? I mean, on the muscle biopsy specimen, what specific test would be done? So your answer would be immunohistochemical staining. It is IHC, that is immunohistochemical staining, that would be done. So it is PCR for dystrophin gene. And it's not gene that is absent, it's the protein that is gonna be absent. No, this is one of the proteins, that is a sarcolemmal protein, regulates calcium entry into the muscle. So it's gonna be like dystrophin gene is absent. The statement is dystrophin protein is absent and not the word dystrophin gene. I mean, the gene is there, it's malfunctioning, that's why the protein part is defective. So okay, we sorted for this one. This is again a twisted question that came in one of the last to last FMG exam. This time it is a boy. He's having very patli si legs. Like you can see, calf muscle to hai nahi, no, right? It's a stork-like appearance which is present. There are contractures in the foot of the patient. So this is a hereditary neuropathy. Just like we are discussing a muscle disease, we are discussing a neuropathy at the moment. This neuropathy is what is called as, yes, Adishri got it correct. More people to comment. Yes, this would be called as Charcot-Marie tooth disease. So both of these are mentioned in the rapid revision section as well. And do take care that there are two questions that have been asked, both for like 10-year-old children. But one was having hypertrophy, pseudo hypertrophy of calf muscles. Second was having extreme atrophy of the calf muscles, that is called as CMT, that is Charcot-Marie tooth disease. Good. Moving to the next one, again a repeat question. He mentioned regarding a person who's having sudden onset face weakness. He's a hypertensive guy, so risk factors were given, atherosclerotic risk factor. He said the symptoms of the patient are resolving in 36 hours. The CT scan of the patient is normal. He says, what is the diagnosis in this particular case? So I can expect an answer from you guys here. Like the cutoff for diagnosis of transient ischemic attack is 24 hours. In this case, it might have taken a little longer also. See, if it was stroke, then there would be no improvement. Like the symptoms are not going to improve in 36 hours, right? Stroke always causes neurological deficit, which is going to persist for a long duration. And anyway, there is no finding. I mean, hemorrhagic stroke can't be a presentation because CT head is normal. And ischemic stroke will also cause like some CT scan findings with 36 hours. So if CT scan is normal at 36 hours and the symptoms are resolving, the correct answer in this case would be given as transient ischemic attack. भाई hemorrhagic stroke होगा तो फिर अगर CT scan करेंगे तो hyperdensity आएगा ना. And if it is gonna be cardioembolic stroke, that means acute ischemic stroke in a patient, then acute ischemic stroke may changes to aayega na. If you are doing a CT scan so late and you are finding that the CT scan is normal, then the possibility of stroke would substantially be reduced. So what I wanted to just highlight from this question is that cutoff for 24 hours is just an artificial cutoff. Sometimes the symptoms, usually TIA symptoms start improving in the first hour only. Na? I mean, TIA agar hai, so symptoms will start improving in the first hour only. But sometimes it may take, a cutoff is 24 hours, it may take 25 hours also, it may take 26 hours also. So it's not that we have to get stuck at only 24. Symptoms can improve in 23 hours also. I said improvement is occurring by first hour, so max improvement would occur in the next few hours only. It might take 23, it may take 26, it may take a little longer, but the point is, if CT scan is normal, then this would be going in favor of transient ischemic attack. Quick answers here. What drug would be started in this patient to prevent the recurrence of TIA events? We have done the ABCD2 score in this patient, and ABCD2 score, I'll just mention the parameters here: age, blood pressure, clinical features, then is duration of symptoms, And then what I've also taken care is diabetes mellitus, and I have calculated the chances of development of stroke in a patient, chances of occurrence of stroke in this patient in future. ABCD2 score is used to decide the need for development of anticoagulation. And he says like, what is the treatment to be done in this person? Then answer would be aspirin. Yes, very good. It is aspirin. Usually we give a dual antiplatelet therapy, so aspirin with ticagrelor is the main treatment which would be answered for this question. Yeah, NOACs, doctor, I would say are only to be done if the echocardiography of a patient is showing presence of clots. Otherwise, we'll not be going ahead with using novel oral anticoagulating agents. I'll just use a separate color to highlight it. Only in the workup of this patient, if the echo is showing evidence of left atrial clots, that is when we will be starting these patients on novel oral anti-clotting drugs. But without that, obviously, it is aspirin and ticagrelor, which would be a single best answer for this question, that is dual antiplatelet therapy. If it is ischemic stroke, then the window period ideally should be answered as 4.6 hours, though you know the upper limit has been revised. The upper limit is 6 hours, but ideally we should be doing thrombolysis or fibrinolysis within 4.5 hours. And after, if he mentions a question on acute ischemic stroke who's presenting after 6 hours, and he says what is the treatment that would be reserved for this individual, then we'll answer this as thrombectomy. We can be treating stroke patients up to 24 hours. We can be treating acute ischemic stroke patients up to 24 hours. It is for the first 6 hours, it would be fibrinolysis with the current edition of the book, and after 6 hours, it's a thrombectomy. Though nowadays they say wherever feasible, try to do a thrombectomy in the patient in the shortest possible time frame. Mechanical thrombectomy is up to a limit of 24 hours. Okay, so what is the drug of choice for hypertensive crisis which is causing left ventricle failure? 30-second, guys. No, we don't use streptokinase here, right? Streptokinase is not used, no. For acute ischemic stroke, there are two drugs approved, no, Elteplis and tenecteplase. Okay, nicardipine, labetalol, and I'll give options, sir. Nicardipine, labetalol, and nitroglycerin. Yep. Guys, it's not nicardipine. If it is left ventricle failure, then the answer for this would be given as nitroglycerin, because nitroglycerin will be a vasodilator, so it will reduce the pulmonary edema. It is also arteriodilator, so it will control the hypertension of a patient because it's a cardiac emergency. Just remember, hypertensive crisis, whenever there's a cardiac emergency occurring in a patient, in a cardiac emergency, the drug that we shall be using for management would be nitroglycerin, not nitroprusside. It is nitroglycerin that will be used. We will just discuss in a couple of minutes when will we be using nitroprusside in a patient and the remaining aspects also. Like if he says patient is having hemorrhagic stroke and there's a rupture of a blood vessel in the brain, one of the blood vessels in the brain is damaged, that is usually the chota branches of the lenticulostriate artery, the penetrating branches are the ones which are damaged in hypertensive crisis. In those circumstances, the answer would be given as nicardipine. If nicardipine is not in the options, then the next best answer in the question would be given as labetalol. Let the system come back again. Yep, I said if it is a hemorrhagic stroke in a patient, then it is nicardipine. And if this is not in the options, then we will be happily answer labetalol. So the message is for hypertensive crisis, if it is causing a cardiac emergency, for cardiac emergency, we shall be using nitroglycerin. But if it is a neurological emergency, then we shall be using labetalol or nicardipine for management of this patient. And then he says there is a patient on hemorrhagic stroke, as we can see here, and he says which of the following is not to be done in this particular case. So yes, guys, I think people have already commented for the current question in the highlight. I'm going to give you a couple of more seconds to finalize the answer for this question. There is a brain hemorrhage occurring in this patient. You can see that there's a hyperdensity, right? So there's a brain hemorrhage occurring. And this is again a repeat question, right? When the person is having a brain hemorrhage, what will not be done? So if there is posturing in a patient, guys, if somebody is having raised ICP due to brain hemorrhage and person is having posturing, then I don't have an option. No, I can be doing is mannitol for this patient, but there is no rule of thrombolysis in this particular case. Thrombolysis nahi karenge is case mein. Securing airways, they are important. I need to give labetalol to this patient to control the blood pressure, but what we will not be doing in this patient is thrombolysis, क्योंकि यार thrombolysis करेंगे तो उससे तो bleeding और ज़्यादा बढ़ जाती है ना. आपको पता ही है thrombolysis का जो biggest side effect होता है The biggest side effect of thrombolysis is bleeding, and there is already a bleeding happening in the brain of the patient. So this would be a gross medical negligence that would come up. The question is simply testing your baseline knowledge, guys. I mean, FMG exam they just put baseline information that hemorrhagic stroke में thrombolysis नहीं करते हैं क्यों, क्योंकि bleeding हो जाएगा, already bleeding हो रहा है, the bleeding will worsen in this particular case. So the answer for this case would be option number B. And then another thing that I want to bring to your attention is they put up a question on subdural hemorrhage always. That subdural hemorrhage will always be having is a development of concavo-convex. Like they will always be giving you an image in which you will be able to notice that there would be a concavo-convex hyperdensity present. All I'm trying to say here is that if it is going to be white in appearance, then answer it as acute subdural hemorrhage. But suppose in a question they give you this concavo-convex hyperdensity and you notice it is black in color, then you will say it is a chronic subdural hemorrhage. I have just hand drawn this before you. If it is the black one, you will say it is chronic. If it is gonna be white, then you're gonna say it is an acute subdural hemorrhage, and the treatment of the two is different, and that is why I have just mentioned this statement here. There's rupture of cortical bridging veins, that is okay, but in acute subdural hemorrhage, if he says what will you do, then for acute subdural hemorrhage it is a craniotomy. But if he says what will you do in a chronic subdural hemorrhage, then answer would be given as a burr surgery. So just get that data right. For acute subdural hemorrhage, he'll give you a CT scan like this. He'll say what is the like he'll not say what is the spot diagnosis. He will say what is the treatment formulated for this patient. So for the acute subdural hemorrhage, your answer would be given as craniotomy, and for the chronic one, your answer would be given as a burr hole. So I've discussed two important CTs at the moment where I mentioned like what is to be done and what is not to be done, and along with these two standard questions which I'll repeat once again in case you got them incorrect is hypertensive crisis every time is asked in the exam. तो आप देख लो कि कार्डियक इमरजेंसी है, न्यूरोलॉजिकल इमरजेंसी है. अगर वो ब्रेन की इमरजेंसी होगी तो आप आंसर करना निकार्डिपिन, लेकिन अगर हार्ट की इमरजेंसी होगी तो आप आंसर करके आना नाइट्रोग्लिसरीन. I mean that's the basic point, guys. Nitrates, why we are talking about nitrates at the moment is because it's gonna reduce the, it's a vasodilator, right? So it's gonna reduce the preload of the heart, it will reduce the pulmonary edema component. That is why like we are using nitroglycerin for this patient. So two in fact four very hardcore general medicine questions which have come in the paper are what I'm discussing once again before you. Must know fact for everybody. Hypertensive crisis with heart failure, it is nitroglycerin as a drug of choice. If it's gonna be a brain hemorrhage, then we are gonna be using nicardipine. What you don't do on a brain hemorrhage is obviously thrombolysis. It's conservative management of hypertension that would be done along with control of raised ICP. And if they give you a question which is based on subdural hemorrhage where there can be mass effect, there could be like a midline shift happening, there could be a transtentorial herniation occurring in a patient, then we need to act. And what is the action that we're doing in a case of a chronic acute versus a chronic subdural hemorrhage is the questions that have been asked. The white is the acute subdural hemorrhage. It's going to be answered as a craniotomy. And if it's going to be the chronic subdural hemorrhage, then it's going to be answered as burr hole surgery. Okay. Let's move to the next one. This is a case where there is a lady and she's having like blindness after her delivery. The BP is shooting up to 200 by 120 and MRI is showing a cerebral edema. So he's saying like what is the diagnosis in this particular case? It's not a hard and a fast rule for that 72 hours and 3 weeks. I mean, that is not a hard and a fast rule. No, that symptoms will occur within 72 hours or within 3 weeks. Like it can vary. So let's not go by time frame there. Yes. Lady after delivery is having blindness. The MRI is showing occipital lobe with the cerebral edema. You just need to go by English here that it's a posterior. No, occipital lobe पीछे होता है, posteriorly located. So this would be a posterior reversible encephalopathy syndrome that has occurred in this patient. This lady could be having is a pre-existing hypertension, and the answer in this case would be given as a press. Just use English here. I mean, occipital lobe cerebral edema is described in a question. Eclampsia will contribute to development of seizures and again a cerebral edema, but it would not be limited to, it would not be restricted to the occipital lobe. So this is again an important question to be remembered. That would be press posterior reversible encephalopathy syndrome. What would be the drug that would be used in this case, guys? How would you lower the blood pressure of this patient? A posterior reversible encephalopathy? Yes, guys. Best drug for press. The answers were correct, but we need to figure out the answer for like control the blood pressure of this patient. So yes, guys, very good. Yeah, we can use nicardipine, we can use labetalol in this patient. So there's so many drugs which are available. I can even use sodium nitroprusside, but because nitroprusside has the risk of causing cyanide toxicity, so we are more comfortable using nicardipine and labetalol for. I mean, whether you said nicardipine, whether you said labetalol, wo chalega, that is perfectly fine. The only question where I am mentioning sodium nitroprusside. The only question where I'm mentioning sodium nitroprusside comes now, that if he says intraoperative hypertension during pheochromocytoma surgery, that's the point to be remembered. Whenever there's going to be tumor manipulation by the surgeon during a pheochromocytoma surgery, that is when you will be answering this as sodium nitroprusside. So the point is sodium nitroprusside is a very good drug to control the elevated blood pressure, but because it causes a very precipitous fall in the blood pressure and the concerns for toxicity, therefore, sodium nitroprusside would be answered in the following scenario. For management of pheochromocytoma surgery only, it would be answered. Otherwise, like the answers are gonna be labetalol nicardipine for CNS events, labetalol and nicardipine for CNS events, and nitroglycerin for cardiac events. Yeah, drug for preoperative hypertension in pheochromocytoma. Yep. This is not gonna be phentolamine, right? Preoperative hypertension in pheochromocytoma. Yeah, I mean the phenoxybenzamine is the main drug that would be used, and yeah, we can be using even phenoxybenzamine. We can be using phentolamine in these patients as well, but then phentolamine would not be recommended as a single best answer. First best answer for intraoperative is sodium nitroprusside, and if he says before the surgery of the patient is done, then what drug would be used? Then first drug that will be starting the patient is oral phenoxybenzamine. You know, I need to prep the patient. I need to get a pre-anesthetic fitness and a pre-PSE done. So phenoxybenzamine is the initial drug that would be used, and it is alpha and a beta blocker that would be used. So it is like phenoxybenzamine and then propranolol that would be used for management of this patient. We will be using phentolamine just before we take the patient into the OT also. But at the moment, like we are talking about medical stabilization of this case. Then he's asked regarding management of hypertension and coarctation of aorta. The keywords for identifying the question would be radiofemoral delay, because most of the time the coarctation of aorta would be involving the descending part of the aorta. So how do you manage the hypertension in this case? Quick answers here. Radiofemoral delay is one of the hints that are given in the question. Others could be like there could be difference in the blood pressure between the upper limb and the lower limbs of the patient, because BP in the legs would be lesser because there's a narrowing, and in the upper limb would be more. Guys, here the answer would not be drugs. The only scenario where you don't answer drugs for management in a hypertension case is for coarctation of aorta. Your answer is balloon dilatation. Yep, not angioplasty, because angioplasty is done for coronary artery, so it's a balloon dilatation of the aorta that would be done in this case. This is the only question where the answer would not be given as drugs. Calcium channel blockers are given in bilateral renal artery stenosis, and in unilateral renal artery stenosis, it is ACE inhibitor. So answer is not CCB or hydralazine. Balloon dilatation of the aorta is the main treatment for coarctation of aorta. Then another question in the paper said, which condition will be having unequal BP between the upper limb and the lower limbs? As I said, because of the narrowing of the aorta, there would be less BP in the legs and the BP in the upper limbs would be elevated. So, I mean, that's pretty straightforward. And then there is a question regarding unequal BP between the left and the right arms, and the patient is also having a bruit over the renal artery. So this time the answer is not coarctation of aorta, primarily because one is talking about bruit over the renal artery also. So yes, guys, bruit over the renal artery, very good. It is Takayasu's arteritis. Takayasu will be causing ostial narrowing. The concept here is that renal artery का जो opening है वो छोटा हो गया, subclavian artery का opening छोटा हो गया. तो अगर opening छोटा हो जाएगा तो less blood will be going in those blood vessels, and if less blood will go in the blood vessels, then there would be pulseless disease occurring in a patient. So this would be Takayasu's arteritis. Most of the time it's the left subclavian artery that would be involved, but apart from this left and the right subclavian artery, even the renal artery of the patient can get involved. So the answer would be given as Takayasu's arteritis. Next is a question on unequal blood pressure between the left and the right arms in a hypertensive patient with pain in the interscapular area. Like patient is having very severe chest pain. So asked him, put your hand on the chest wherever the pain is. He did not put his hand in the front. He put his hand like this in the interscapular area. The moment you read about the chest pain in the interscapular area and there's the unequal BP between the left and the right side, then you will change your answer to that of aortic dissection, in which we do a CT angiography, and this CT angiography will be showing is a tennis ball appearance. It would be a type, it can be a type A aortic dissection, or it can be a type B aortic dissection in a patient. So it is, I mean, tennis ball appearance that would be present of the intimal flap. Okay, moving and shifting gears, we have this 50-year-old man. He's having fever for 1 day, and there's the altered sensorium with the bilateral Babinski sign. The HRP2 CAR test is positive. That's the hint in the question. Let's have answers here. Yes, guys. Yep, because the histidine-rich protein test is positive in this case. So what we are thinking in terms of is cerebral malaria. That cerebral malaria is causing irritation in the brain, and that is why like this chap is having a bilateral, because the corticospinal pathway is affected, the blood supply, because what happens in malaria is RBCs become sticky, वो आपस में चिपक जाते हैं, so there is a like micro infarctions occurring in the brain, and if the blood supply, the corticospinal pathway is affected, that's why like there would be this Babinski sign that's coming up in this patient, along with diffuse cerebral dysfunction or a development of altered sensorium. The next question talks about ipsilateral loss of proprioception in a person. That tells me that the part that is affected is the dorsal column. And along with this, is also saying that the person is having contralateral absence of the ankle jerk and a collateral Babinski sign that is occurring in this patient. So there are like two things given: ipsilateral proprioception, and then there's a contralateral absent ankle jerk, and there is a contralateral Babinski sign that is happening. If you look at the absent ankle jerk in the patient, this could be because there is a peripheral neuropathy, and along with that there is a collateral Babinski sign. That Babinski sign is coming up because in this particular patient the corticospinal pathway in the spinal cord is getting involved. This is not going to be a presentation of Brown-Séquard syndrome. In Brown-Séquard syndrome, the question will always mention contralateral pain and temperature. Here it is not talking about any pain and temperature. It is contralateral absent ankle jerk as well as Babinski sign. So what is happening is motor pathways are also involved, and the sensory pathways in the patient are also involved. This would be a presentation of subacute combined demyelination of the spinal cord, which would be having vitamin B12 deficiency. The answer for this question, do remember, if he says ipsilateral loss of proprioception with contralateral pain and temperature loss, then it is Brown-Séquard syndrome, that is hemisection of the spinal cord. Don't assume answers to a question. That is what I'm trying to tell you, that we are not focusing on rectification. We are trying to build up concepts here. That is the primary objective of the discussion. I mean, I want you guys to have focus like a hypersonic missile, that you have to reach the target. Now, if you look at the next question, there is loss of pain and temperature along with preserved proprioception in a patient. That is what is like the sensation loss is occurring in the arms. Like thus the pain and temperature sensation is getting lost in the arms of the patient, it is getting lost in the hands of the patient. So that is what is called as a cape distribution. Cape is like a chunni, no? Cape is like a shawl that we put, right? A chunni is like what women would be putting, like salwar kameez ke saath mein. So it's like a patchy loss of pain and temperature that is happening. This would be a presentation that would be seen with syringomelia. So the learning point for you guys is, don't assume Brown-Séquard for every question that talks about ipsilateral proprioception loss. That's the final message. If it talks about ipsilateral proprioception loss with contralateral pain and temperature, I mean, understandable Brown-Séquard, but here it was combination of sensory and motor manifestation. So it is combined demyelination of the spinal cord for point number 43, and in 44 it is that cape distribution of loss of pain and temperature in both arms with preserved proprioception. That is why we call it dissociated anesthesia. That dissociative word is mainly used to explain that two sensations are lost, pain and temperature, and proprioception is preserved in the patient. So the correct answer for this one would be given as syringomelia. For 44 and for 43, I'm still getting in the question answer as Brown-Séquard. As I've explained, Brown-Séquard will be having pain and temperature loss of the contralateral side getting affected. Here it was not mentioning pain and temperature, but was talking about peripheral neuropathy and Babinski sign. Okay. What is the leading cause of 45, please? What is the leading cause of subcortical dementia? 45. Yes, guys. Leading cause of subcortical dementia is Parkinson disease. Very good. And the leading cause of cortical dementia is Alzheimer's disease. If I remove the word sub word here, and if I say cortical dementia, then answer would be given as AD, and if I say subcortical, it is Parkinson disease. Now we move on to 46, where there was a question or a concept related to a man who's having dementia with bradykinesia. Dementia is a feature that we read with Alzheimer, and bradykinesia is what we read with PD, and here a combo was given. Patient is also having recurrent falls. There is a chorea, and the key word in the question was family history of similar illness. Then you know that PD may not occur in the next generation, AD may not occur in next generation, but Huntington's chorea occurs in next generation due to autosomal dominant pattern of inheritance. So the answer for this one would be option number B. The hint in the question would be chorea. The learning point for you is if he mentions regarding a question which is having dementia, bradykinesia, and chorea, then chorea is a very easy word to solve the question of Huntington's chorea, because chorea you will read two times only. Either it is Sydenham's chorea of rheumatic fever, or it's going to be Huntington's chorea that we are discussing at the moment. And the pattern of inheritance of Huntington's disease would be answered as autosomal dominant pattern of inheritance, which is the reason why in this condition you would be having is a positive family history. The condition will be having excess of dopamine and deficiency of GABA. From the neurotransmitter perspective, it is dopamine that is more and it is GABA that is less. And therefore, we will be using dopamine depleters for management of this patient. The drug that we use in this patient for dopamine depletion is tetrabenazine. That is like not levodopa. Levodopa will increase dopamine levels. It will worsen this guy. It is like what we need to do for this chap is use a dopamine depleter like tetrabenazine. Yeah, trinucleotide repeats, CAG repeats. Yeah. This CAG segment would be repeated multiple times. Usually more than 40 repeats would be present for the manifestations to occur. Okay, moving to 47, which is a must-have criteria for diagnosis of PD. You have your options right here in front of you. The mnemonic for manifestations would be tremors, rigidity, akinesia, and postural instability, or TBR like tremors, bradykinesia, rigidity, whichever you are comfortable here. Chorea is like a dancing movement only, no? A dance movement. Like normally we are sitting, we're not dancing here. Like one hand is showing a dancing movement. That's because caudate nucleus is responsible for suppression of unwanted motor movements. Like if you're seriously studying, then you won't be dancing, right? But if your one hand is dancing, that means that the unwanted movement is happening. That's why choreoform word is used. Yes, a must-have criteria for diagnosis would be given as B, that is bradykinesia. That implies that the person will be very slow in performing any task, and then later could be developing akinesia and akinetic mutism as well. The next one is, all four are present, but then he says must-have criteria for diagnosis would be given as bradykinesia. We cannot diagnose it. Then anti-flu drug which is used for management of PD would be answered as amantadine. And why do we use amantadine is mainly because when we give levodopa, there are a lot of side effects that come. One of them is a peak dose dyskinesia. So for management of that peak dose dyskinesia, which is induced by levodopa, we shall be using amantadine. The rationale why do we use amantadine in PD is because levodopa, when the level of levodopa will spike, it will cause a peak dose dyskinesia, and to minimize those peak dose dyskinesias, that's why amantadine would be used. Then he's asked about the Tauji-wala disease, that is tauopathy. Alzheimer's disease, he asked what is the best imaging modality for this condition. So you guys can quickly comment like what is gonna be the best way for identification. Yes, we'll be going in for a PET. That would be answered as a amyloid PET scan. Instead of amyloid PET scan, another one that I can be using is a functional MRI. The next one talks about imaging modality of choice for insulinoma. Yes, guys. For insulinoma. This would be a pancreatic neuroendocrine tumor. One of the most common functioning pancreatic neuroendocrine tumor happens to be insulinoma. What is going to be used for imaging modality of choice? Endoscopic ultrasound is a good one. MRI is a good one. I think I've updated this. I've explained this multiple times. This is a hot favorite of your examiner, guys. Gallium-68 dotatate PET CT scan is going to be answered by you as the investigation choice for all the pancreatic neuroendocrine tumors. Remember, this is a rule. Don't answer somatostatin scintigraphy. Do not answer endoscopic ultrasound. That is old information. The update what they have asked in the exam multiple times is what is the imaging modality of choice, whether it says insulinoma, glucagonoma, somatostatinoma. Your answer is pancreatic neuroendocrine tumors is gonna be gallium-68 dotatate PET CT. And even for pheochromocytoma, you'll not answer a MRI. not that you were wrong. I mean, somebody did answer an MRI. Yeah, we can do an MRI, right? But if the size of the tumor is small, then it may not be detected on an MRI only. That is why we need to go for an alternative way. So both for pheochromocytoma and pancreatic neuroendocrine tumors, they'll have to ask about a rotated PET CT, and then he talks about investigation choice for insulinoma. So you guys can tell me here. Yes, Jignesh has given up that answer, but still 51. Yes, guys, hit the comment button. In what is the investigation choice for insulinoma? Yes, it is 72-hour fasting. And in the 72-hour fasting, we will be checking the values of random blood sugar. We will be checking the C-peptide values. And along with this, we'll also be checking his RIA fasting insulin levels. What you will notice in this patient will be the random blood sugar will be less, but C-peptide and insulin will be high. I mean, that helps in identification. After sulfonylurea abuse has been ruled out, random blood sugar will be low, C-peptide will be more, insulin will be more, because it's after all a tumor of the beta cells. Okay, guys, let's move ahead to the next one. This one was very good evening, everybody. Okay. Dermatitis, depression, diabetes would be seen in the couple of D's that are given in this question. These D's would help you in identification, right? Yes. Because of dermatitis, depression, and diabetes, the answer is not pellagra or niacin deficiency, guys. Niacin deficiency will not be having diabetes, na. I mean, diabetes mellitus है यार, उसका blood sugar बढ़ा हुआ है, तो blood sugar क्यों बढ़ेगा? Because this guy is having a glucagonoma. This was again a very classical FMG exam question that came up. So I think that there should not be like any issues with respect to answering this one. What you need to understand is that if a person is having glucagonoma, that is a pancreatic neuroendocrine tumor, that the blood sugar of the chap would be elevated, plus there is dermatitis, depression, and another feature that we see in these patients is also deep vein thrombosis. So just like you know the D's which are related to, niacin deficiency, in a similar spirit, what you need to remember is okay. Just like you are aware of the D's that are related to niacin deficiency, where there's a corn eater, there would be diarrhea, dermatitis, and dementia. No, here there was no mention of any dementia. There was no, I mean, here the main feature was diabetes. That's the word that I expected you guys to pick it up, and that would help you in analyzing this correctly. Okay. Yep. So subsequently, like when I did a course correction, everybody was able to get to the correct answer. The answer here would be option number D. Main concept is guys, सीधा D वाले पढ़ के मतलब नाइसिन मत बोल देना, या पेलेग्रा मत बोल देना. चेकआउट की डायबिटीज लिखा है कि नहीं, डिप्रेशन लिखा है कि नहीं, क्योंकि वहां पे तो डिमेंशिया होता है ना. इट इज डायरिया, डिमेंशिया एंड डर्माटाइटिस. यहाँ पे तो ना तो डिमेंशिया वाला कॉम्पोनेंट लिखा है, ना ही यहाँ पे आई मीन देयर इज मेंशन ऑफ एनी like the totally different ball game. And yes, I mean that is the word I was waiting for, कि कोई मेंशन करेगा कि डर्माटाइटिस का डिफरेंस क्या है. तो जो नाइसिन डेफिशिएंसी होता है उसमें तो कैसल्स नेकलेस होता है, जो नाइसिन डेफिशिएंसी होता है उसमें तो कैसल्स नेकलेस होता है. लेकिन यहाँ पे जो डर्माटाइटिस होता है उसके बारे में भी उसने पूछा हुआ है, दो इट इज कवर्ड इन डर्मेटोलॉजी, but one student did mention it, so I have to say this very one, that you have given up a very good answer there. That is necrolytic migratory erythema is a feature which is seen in patients having glucagonoma. This would be like migratory erythema, not a migratory superficial thrombophlebitis, but a migratory erythema that would be useful for diagnosis. So we are sorted for this, guys. The basic point is like, don't look for the D component there, diarrhea, dementia, dermatitis, that's okay. But this time it is going to be the depression and diabetes mellitus that helps you identify that the question is on glucagonoma. Very good, very good. Deepak, just modify your statement there. Diarrhea, okay. Glucagonoma may not be having a secretory diarrhea, so I'm not very comfortable. But the first four features of yours are perfectly okay. Then he says, what is the most common non-functioning pancreatic tumor? The functioning pancreatic tumor is the insulinoma. I think I've answered majority of queries. The most common functioning pancreatic tumor is a insulinoma, for which we do a 72-hour fasting test and a dotatate PET CT scan. But then if he says what is going to be a non-functioning pancreatic tumor, then your answer would be given as PPOMA, that is pancreatic polypeptide. This is the PPOMA. it's gonna be producing pancreatic polypeptide. So I wanted to hear that that would be even Zollinger Ellison coming up. So Zollinger Ellison कब आंसर करना होता है उसको देखो. If he says what is the most common functioning pancreatic tumor in a case of multiple endocrine neoplasia type 1, फिर आप आंसर करके आना. Then you have to change the answer to that of Zollinger-Ellison syndrome. So there are three questions which are to be remembered. If it says non-functioning pancreatic tumor, PPO में होता है pancreatic polypeptide. यहाँ पे कोई भी endocrine manifestations do not come because pancreatic polypeptide is gonna be like a biologically inactive molecule. Because it's a biologically inactive molecule, it's gonna produce only mass effects present. If it is functioning pancreatic tumor, then yeah, hypoglycemia episodes will occur. Whipple's triad will be present there. Whipple's triad would be hypoglycemia, and then there would be resolution of symptoms with sugar intake, and then there would be rebound symptoms that are developing. And if he says the word multiple endocrine neoplasia, only then it is Zollinger-Ellison syndrome. Now we discuss the counterpart question that always comes. What is the most common pituitary adenoma? You guys can comment here. What is overall the most common pituitary adenoma? Yes, guys. Okay, prolactinoma. Fine. The most common pituitary adenoma. Okay. The most common functioning, The most common pituitary adenoma would be given as prolactinoma. That's an okay answer. I mean, prolactinoma would contribute to then galactorrhea, and it will contribute to menstrual abnormalities in a female. So that's perfectly fine. And then you could be having non-functioning adenomas also. Those non-functioning adenomas would be mainly causing hypopituitarism occurring in a patient. Fine. Then is regarding a tumor that would be contributing to excessive growth hormone, and there would be prognathism. There would be hands and the feet that will be becoming relatively bigger. Spade-like hands is the description that would be given in a question. You guys can comment in the chat box with respect to what would be the screening test for acromegaly. Yes, your answers would be insulin-like growth factor 1 levels. If it says what is the investigational choice for this condition, then your answer would be yes. If it's gonna be acromegaly as investigational choice, then your answer would be given as glucose challenge test. Normally, when you give glucose to somebody, it causes suppression of growth hormone. But in this patient, the growth hormone values will usually remain more than 0.4. That's because the suppression will not happen because the tumor is not going to respect physiology, right? I mean, the tumor is going to do its own thing. So therefore, the growth hormone levels remain elevated in spite of giving sugar. The peculiar thing that you have to remember is glucose is normally, glucose challenge is what you study with respect to diabetes. But today we're talking about an endocrine condition where we are using this. And the initial treatment for this patient before we plan surgery is to shrink the size of the tumor. And the medicine that we give to shrink the size of the tumor would be given as lanreotide, which is again a molecule. Long-acting derivative, lanreotide would be preferred over octreotide for management of this patient. Then he talks about a tumor of the adrenal gland. And this tumor of the adrenal gland is present in the first layer, and it is causing a excess of aldosterone. As a result of this, there's a hypertension, and there is also a urinary loss of potassium and hydrogen. So there's a hypokalemic alkalosis. I think I made the symbolic diagram for it. Yes, you guys were spot on in identifying this. The answer would be given as Conn syndrome, which is characterized by excess of aldosterone, which is why hypokalemic alkalosis would be coming. The next question is again a concept that has been repeated. He is asked about a test that should be done in a Cushing syndrome patient where a high dose dexamethasone suppression test is showing a partial suppression of ACTH, and CRH is showing a 40% or more than 40% increase in ACTH. Even if you don't know about both the tests, I think still the first line of the question, the third line of the question should solve it for you, that he mentions the word partial suppression of ACTH levels. You have to select oat cell cancer of the lung versus pituitary adenoma. Partial suppression. Can you suppress a lung cancer? Can you suppress a lung cancer? Yes, guys. Partial suppression. Read it carefully, guys. I'm changing the question now. This is what has also been asked. No suppression of ACTH levels. I mean, come on, man. If there is no suppression of ACTH levels, that's gonna be lung cancer. But if it's gonna be partial suppression of, that's the word that you need to identify. No, it would be like a maybe a one-liner or maybe sometimes 2 or 3-liner question. The key word is partial suppression of ACTH levels would be a pituitary adenoma. This pituitary adenoma was producing ACTH, and now what you're trying to do is you're trying to suppress it. So pituitary adenoma would be the answer in this case. Along with this, yeah, pituitary adenoma will respond very well to CRH, and therefore there would be a substantial increase in the values of ACTH after CRH was given. But if I change the language of the question and say that the person is having no suppression of ACTH levels, no suppression at all, then your answer would be given as lung cancer, which is causing excess production of ACTH. In the actual question, it was not oat cell cancer. He mentioned the word ectopic source. I mentioned a similar kind of question in Fairly also, but just to bring it to your attention, oat cell cancer was mentioned as ectopic source, understandably so, because normally like we don't have ACTH being produced in the lungs. Then if he says what is the most common cause of Cushing disease, the answer would again be given as pituitary adenoma, which would be referred as an endogenous cause. If I change the language of this question to what is overall the most common cause of Cushing syndrome, then Cushing syndrome would be answered as iatrogenic. That would be, iatrogenic would mean like doctor induced or exogenous cause. Good. Let's move on to the next one where he says what is the most common cause of Cushing syndrome from the following causes. Yes, guys. From the following 4 causes, options in front of you. There is no exogenous in the option, no? Yeah, there is no iatrogenic in the options. Read the question carefully. He says, what is the most common cause of Cushing syndrome? The most common cause is iatrogenic. If iatrogenic is not in the options, idiopathic, no, that's a diagnosis of exclusion, man. Then the most common cause would be ectopic source. No, ectopic source is the second most common cause. Why Cushing syndrome के 4 ही तो cause बताएं. I'm going to write them quickly here. The most common cause is iatrogenic cause. If iatrogenic cause is not there, then it can be ectopic. For ectopic, there can be 2 tumors. One is called as carcinoid tumor and the second one is called as oat cell cancer. Another important cause which is to be remembered is Cushing disease. That would be a pituitary adenoma. For pituitary adenoma, he will write the word endogenous. And then is autonomous source. Autonomous would mean that the person is having a tumor in the second layer of the adrenal gland. That is adrenal adenoma. The total of 4 causes which are mentioned. Just go through the first 5 minutes of Cushing syndrome and you get all those questions that are asked in the topic, right? It is a tumor in the second layer which is called as autonomous source. 4 word याद करने हैं: iatrogenic, ectopic, endogenous, and then autonomous source. That's what you get the data right. And the answer for the 60th concept that I'm telling you for today, if ectopic is not given, I mean, if it's not given, then I'll say, okay, then I mean, ectopic source can be one of the correct answers. Okay, fine. And the basic concept is the total of 4 important causes that I mentioned here before you. And what you need to primarily understand is like high dose dexamethasone suppression test is mainly used for differentiating between the causes. In fact, one more endogenous and autonomous differences. Endogenous causes pituitary adenoma. Okay, very good. Endogenous causes pituitary adenoma. That is a natural site. That is a natural site of production of ACTH. And autonomous source would mean that cortisol. Here it is cortisol that is produced, no? And ACTH in the patient will become suppressed. And in pituitary adenoma, the difference would be cortisol will also, ACTH will also be elevated and cortisol will be elevated. Like somebody said, what is the difference between the two? The difference between the two is that when it comes to pituitary adenoma, then both things would be elevated. ACTH also and cortisol also will be elevated. But when it comes to adrenal adenoma in a patient, then adrenal adenoma is an autonomous source. I mean, it is functioning independent of ACTH, no? So that would be like the difference between the two. Yes. Yeah. I mean, like 4 would be an answer in case like if it's not a if it is not going to be answered as an exogenous cause, then we'll think in terms of endogenous source. Let me just repeat the data. I mean, there are 4 causes that I mentioned here before you. These are the terminologies that I mentioned. I'm not saying they are based on rankings, right? Dr. Hafa, let me clarify. These four causes that I mentioned before you are mentioned on the basis of the terminologies that I want you to get used to. But overall, if I say what is the number one cause, it is iatrogenic. After iatrogenic, the next important cause is endogenous. Endogenous means pituitary adenoma, then comes an ectopic source. So this was for the terminology. This is to make you understand the differences between the four statements. But if he says what is the most common cause, exogenous, then is going to be endogenous cause. Exo, endogenous, and ectopic are the terminologies. I'll say that again, the three E's there: exo, endo, and then the ectopic source would be the answer there. Okay. So I was trying to focus on the vocabulary. That is why maybe that impression was coming that ectopic. Ectopic is primarily carcinoid and node cell cancer that I wanted to highlight. Okay. What is the investigational choice for Cushing syndrome? Quickly, guys. Best test for diagnosis of Cushing syndrome. Yep. Let's have quick answers. Okay, I think you guys are tired at the moment. So the investigation choice for diagnosis of this would be given as salivary cortisol values. This would be a midnight salivary cortisol. Yep, midnight salivary cortisol values would be best useful for management of these patients. The rationale behind this would be that cortisol levels are least at 12 o'clock in the night, and in this patient, the midnight salivary cortisol values would be super elevated. Then is carcinoid. This is a urine test. This would be a 24-hour urinary 5-HIAA levels. That would be hydroxy indole acetic acid levels. Very good. Let's move on to investigational choice for diabetes insipidus. Hit the comment button, guys. I need to tell you again and again, like, you just have to do it fast, no, because we need to invest in time utilization for this one. Diabetes insipidus, the test would be done as a water deprivation. Very good. Normally, when a person is subjected to water deprivation, the urine becomes concentrated, but here the urine will still remain dilute. Then CT head in diabetes mellitus, diabetes insipidus will be showing is a loss of pituitary bright spot. Normally, the posterior pituitary is very visible, but in this particular case, there would be a loss of pituitary bright spot because the posterior pituitary is damaged in this case. The drug of choice for central diabetes insipidus would be desmopressin, which can be written as DDAVP. And if he says, very good, and if he says what is the drug of choice for nephrogenic diabetes insipidus, then we will be answering it as thiazides. Yeah, desmopressin and DDAVP would mean the same. And if it says nephrogenic, then answer would be given as thiazides. Great. Investigational choice for SIADH would be English to be deployed. Earlier we were using the word water deprivation, and now we are going to change it to water loading test. Earlier it was water deprivation test, now it is water loading test. The drug of choice for this would be where we will try to block the action of V2, and therefore we can be using molecules like tolvaptan for these patients or conivaptan. So vaptans are the drug of choice for management of SIADH. Additional point to be always remembered is SIADH is always going to contribute to euvolemic hyponatremia. I mean, the options in the MCQ will be hypovolemic, hypervolemic, and euvolemic. So remember, more water will cause dilution, and the dilution part would be called as euvolemic hyponatremia present in these patients. Great. The next question is a clinical one based. Man is having low testosterone, low cortisol, low GH, and increased prolactin. Majority of the hormones which are coming from the pituitary are getting affected because testosterone is less in this person, because after all, like, what's going to happen is that if LH and FSH values will be affected, then in this person the testosterone values, LH is less, so that is why the testosterone values in the patient is becoming lesser. At the same time, low cortisol because ACTH is also becoming lesser. Growth hormone is also becoming lesser. So the person is having pan-hypopituitarism. Guys, think logically. In prolactinoma only, in prolactinoma, only prolactin will be increased now. In prolactinoma, only prolactin will be increased. The remaining things will not become lesser. No, this patient is having basically a pan-hypopituitarism. So which among the four can be causing is a pan-hypopituitarism, is a non-functioning pituitary adenoma. When a non-functioning pituitary adenoma does not produce any hormone now, when a non-functioning pituitary adenoma will not be producing any hormone, then it can have a mass effect. And because of the mass effect, it will be causing damage. So the basic concept in this question is pan-hypopituitarism is occurring, and pan-hypopituitarism implies the majority of hormones. I mean, definition is all the 6 hormones should become lesser, but then the point is prolactin, why it is more is because of loss of inhibitory control. No? If the pituitary stalk is compressed by the tumor, then because of the stalk, if the pituitary stalk has a inhibitory control over the release of prolactin, so because of the loss of inhibitory control here, the prolactin levels are becoming lesser. So the patient is having a presentation of pan-hypopituitarism with increased prolactin. Why prolactin? Because loss of inhibitory control is there. That is because of a non-functioning pituitary adenoma. That's the peculiarity. Non-functioning pituitary adenoma does not produce any hormone, but at the same time it's going to produce a mass effect, because of which this hypopituitarism manifestations will occur. Moving to the 66th concept for today, what is best for monitoring of diabetes mellitus? Yes guys, hit the comment button. Continuous glucose monitoring, HbA1c, best for monitoring a diagnosed case of diabetes mellitus. He is already diagnosed as diabetes mellitus. Yes. Now answer is not HbA1c guys, answer is continuous glucose monitoring, क्योंकि डायबिटीज mellitus में शुगर बढ़ता है पर शुगर क्रैश भी तो करता है. In diabetes mellitus, the sugar will become lesser also. If hypoglycemia is occurring in a patient, then HbA1c will not sell. See, the question is not on diagnosis. If the question mentioned, I said that already, patient is already diagnosed. If the question said what is the best test for diagnosis of diabetes mellitus, obviously HbA1c values more than 6.5% is more than sufficient. But the question is asking regarding monitoring of diabetes mellitus. Mark my words there. The question is not on diagnosis or diabetes. It's not on diagnosis or diabetes. It is for monitoring of diabetes mellitus. Diagnosis is HbA1c, and when it comes to when it comes to monitoring, then it is continuous glucose monitoring, where the sugar will become more and less, and both can be picked up. Okay, let's have comments from you guys. What is the best drug to be started to reduce the microvascular complications in a newly diagnosed case of diabetes mellitus? The HbA1c is like super elevated, 11%. Yes, I've had a couple of answers. Very good. The patient is having a HbA1c of 11%, is a known case of type 2 diabetes mellitus. You have to start treatment of this patient. So the best drug that you will start in this patient will not be oral hypoglycemic drugs. I've explained to you in type 2 diabetes, if HbA1c is more than 10%, we start the patient straight away on insulin. We have to start treatment. No, at the moment is not talking about cardiovascular mortality. So not all MCQs will be having answer as gliflozin, and not all MCQs will be having answer as semaglutide. If the question said how do you reduce how do you reduce cardiovascular mortality, or what is the best drug for cardiorenal benefit, like suppose this question was cardiorenal benefit in a case of diabetes mellitus, then gliflozins are okay as an answer. But I did not, the question is not saying cardiorenal benefit. Question is just saying you have to start treatment in a person with type 2 diabetes mellitus. What should be done? So either I have to start metformin, that's the main treatment for type 2 diabetes, or we have to start on insulin, because the HbA1c is elevated. That is why insulin would be started in this patient. So the question is not based on cardiorenal benefit. It is based on the treatment for type 2 diabetes. The learning point is, if HbA1c is between 7% to 8%, conservative management. 8 to 10%, it is metformin. If it is going to be in excess of that, then okay man, then you're going to start insulin in the patient. The answer here is B. Coming to 68th concept, cardiorenal benefit, except, here the question is except one. So SGLT2 inhibitor is obviously one of the drugs that causes a cardiorenal benefit. Yes guys, which of the following is not gonna be useful? So ACE inhibitors will reduce the damage in the kidney. Findranon also has been shown to reduce the damage in the kidney. Then the answer in this case would be D, that is rosiglitazone. Rosiglitazone worsens it worsens cardiac mortality. If cardiac mortality is worsened, then even the renal mortality would be affected in a patient. So the 68, there are two concepts guys that I'm giving in this question. One is treatment of diabetes, type 2 diabetes, HbA1c between 8 to 10%, metformin. To that you add semaglutide. To that you add drugs like gliflozins. But if HbA1c is more than 10%, you start straight away with insulin. And for cardiorenal benefit, SGLT2 inhibitor, agreed, but here it was except question, so therefore the answer would be given as like rosiglitazone. Yeah, Tejas, that's good. Roses are bad for the heart. They're supposed to be good, actually, a cure for the heart, but anyway. Okay. Which of the following is once a week insulin injection? 69. This is based on your exclusion capabilities. Yes, guys. Let's have quick answers there, which is once a week insulin. Degludec will work for 42 hours. Glargine will work for 24 hours. So here it is hours and hours, and this is ultra short acting. No, aspart will be acting for maximum like about 3 to 6 hours only. So the answer is to be given by exclusion. That is like once a week insulin injection would be Ecodec. That will work for like almost 7 to 8 days. So lots of time the questions are to be answered on the basis of exclusion capability as well. Moving to the 70th concept for the day. Patient of RTA road traffic accident is having a shortness of breath and a drop in SpO2 on day 2 of admission. I mean, a guy had an accident, a nasty bike crash. He's having multiple injuries, and there's a drop in oxygen saturation, and the person is having elevated JVP with dilated right ventricle yes, dilated right ventricle on an echocardiography. Yes, guys, you have to select between fat embolism and pulmonary embolism. Very good. Because the patient is having elevated JVP, that is to small sign and dilated right ventricle, that means there's a clot present here, and therefore the answer in this question would be given as pulmonary embolism. Very good. PE would be the answer in this case. Now let us change the question, and there is a patient of road traffic accident with shortness of breath and drop in SpO2 with altered mentation being given, and petechia also given. So in this question, lung involvement is given because there's a drop in oxygen saturation. There is a CNS manifestation given, that is altered mentation. There is petechiae which are present in this patient. These petechiae are present on the anterior chest wall or on the axle of the patient. So in this case, the answer would be given as fat embolism syndrome. Basically, the GERD criteria are getting satisfied in this condition. So usually like one question always comes on fat embolism versus pulmonary embolism. That's the differentiating that you need to remember, that if he mentions features of heart failure, then answer is pulmonary embolism. If he mentions CNS manifestations and development of petechiae, then you have to think in terms of answer as fat embolism syndrome. Then is prevention of asthma. What anti-IL-5 injection? In fact, you can answer from the comments. The answer is almost given there as well. So yes, guys, asthma injections have to be given. Anti-asthma injections which can help in preventing asthma attacks. So that would be mepolizumab, that is anti-IL-5 injection that would be given. So monoclonal antibodies would be given. Yes, benralizumab and mepolizumab are the molecules that would be used in this case. If we mentioned regarding anti-immunoglobulin E molecule, then omalizumab would be given. And if it talks about interleukin 4 and interleukin 13, then it is dupilumab that is to be answered. So do remember the statements that I've currently mentioned before you. For interleukin 5, it is mepolizumab. For interleukin 4 and interleukin 13, it is dupilumab. And for omalizumab, that is relatively easier. Yes, Deepak, you were right. And then the latest drug that is approved for asthma is tezepelumab. That will work in both type 1 as well as type 2 inflammation in asthma. Very good. Okay, so to see that you got these concepts right or not, please comment in the chat box. For management of severe eosinophilic asthma, the eosinophil count of the patient in the sputum is elevated. Like the test we are doing in this patient is sputum eosinophil count. The sputum eosinophil count of the patient is like severely elevated, like 300, 400, like that the value is given. And he says what drug would be given for management of this patient. So let's hit the comment button, guys. Best management for severe eosinophilic asthma. Yes, the correct answer for eosinophilic asthma would be mepolizumab and not omalizumab. If I said omalizumab, then omalizumab would be answered. If I mentioned regarding immunoglobulin E, no. If my question said that this person is having elevated immunoglobulin E levels, then it is omalizumab. If it is gonna mention about eosinophilic asthma, that is type 2 asthma basically, then it is mepolizumab that would be answered. So that's the main concept, guys. Yeah, exactly. NASA, that's a good name that you've kept, a pseudonym that you've kept. That mepolizumab is it's gonna take care of interleukin 5, which is chemotactic for eosinophils. So like it's testing both your I would say pathology as well as pharmacology. And for those of you who could not get this correct, remember, if he says the word allergic asthma, then your answer is given as omalizumab. But if he says the word eosinophilic asthma, Then for eosinophilic asthma, your answer would be given as the following drugs for interleukin 5, interleukin 4, and interleukin 13. So do take care of those words there. Allergic asthma written, then it is omalizumab. If it is eosinophilic asthma, then it is the drugs which are mentioned. And then the last comment in the chat box tells us regarding that ability for us to be able to interlink the pharma with the pathology information. Okay, so I think you can therefore answer 74 also. That decision to add steroids in asthma patient is based on, I mean, how does a doctor decide? Obviously, one would be symptoms in a patient, but apart from symptoms, because they're very subjective, right? I mean, patient may see, a clinical assessment can be biased because lots of time people are not taking the puffer properly. If you're not explaining to the patient how to take the puffer and there is a poor hand breath coordination, I mean, the problem most of the time for poorly controlled asthma, if he says what is the leading reason that we get is a poorly controlled asthma, then the problem is not with your prescription. You have written the right amount of drugs. The problem with asthma control is mainly a hand breath coordination of the patient is poor, and if a person is not able to take the puffer properly, then in those circumstances, I mean, the word is poor hand breath coordination, then in those circumstances the asthma will not get controlled. So the main test that we use is sputum eosinophil count, and this helps us in guiding the treatment for asthma patients, because anyway, if it's type 2 asthma, eosinophilic asthma, the eosinophil counts would be severely elevated. 75 is a one-liner question that has come in the exam multiple times, so I do not need to ask you this. He's asked what is the definition of reversibility. I mean, the FEV1 should increase by how much percentage to say it is bronchial asthma. Like before I started my patient on bronchodilator, the person was having a FEV1 of 50%, and suppose it increases to 70% on giving a bronchodilator, then it means the increment is more than 12%, so that is diagnosis of bronchial asthma. The next concept is on COPD. He says, what is best to reduce mortality in COPD apart from quitting nicotine? Obviously, you will tell the guy to, like, stop taking nicotine, understandable. But over and above this, like, what is the main treatment for COPD patients? Like for asthma, it's gonna be mainly gonna be I mean, drug support that has to be given. But in COPD, because the lung damage is extensively present, what is the main intervention that would be helping in this patient? Oh, vaping will not be helping. Yes, it is LTOT. That is not bupropion, not nicotine de-addiction. It is LTOT, that is long-term oxygen therapy. That is the main mortality reducing agent. And what is the best way for quitting nicotine? Nicotine de-addiction, please. LTOT is perfect as an answer. Can you let me know the answer to what is the best treatment for, what is the best intervention that you are gonna be doing in a chap who's gonna be like smoking and puffing on a cigarette? Okay, yeah, nicotine replacement. Yeah, it is nicotine transdermal patches, or we can use a nicotine chewing gum in a patient as well. In fact, it does not need to go to a chemist also. I mean, it's available over the counter. So nicotine chewing gum can be used in these patients and would help him very well. Okay, what is the best management of acute exacerbation of COPD? The PCO2 of the patient is 50. The person is going into carbon dioxide narcosis. The patient is going into type 2 respiratory failure. And considering that the person can deteriorate very bad, I don't want to take a chance. So what is the main treatment that would be given in this patient? Yeah, Nicotex. No, we avoid intubation. No? We avoid intubation because COPD patients already secretions in the lungs. They can become incipitated and there can be infection occurring in a patient. So therefore, in this patient, what we will do is we will go for NIV, that is non-invasive ventilation. You will be asking your nursing staff to help you out with the fittings for getting the machine here, right? The BiPAP machine would be brought, and then you'll do the fittings for an IV, that is non-invasive ventilation. So yep, the correct answer is NIV, and BiPAP would be used in this particular case. When do we use SABA? Okay, so for asthma, if he says acute asthma exacerbation, and he says what will be used for management of this patient, your answer would be LABA with inhaled corticosteroids. Suppose he changes the question to severe acute asthma where the person is requiring hospitalization. The person is having so much of breathing difficulty that he cannot even talk to you. He's having loud rhonchi in the chest. In severe acute asthma, we use SABA nebulization. SABA is to be answered only when he says the word severe acute asthma. Otherwise, for acute asthma, Otherwise, for acute asthma, it is LABA with inhaled corticosteroids. Okay, hit the comment button. I would like everybody to comment there with respect to 78. The interpretation, I mean, options are obviously metabolic acidosis, alkalosis. So obviously it is acidosis only. And all the three arrows are going down, down, down in a patient. So this tells me it is metabolic acidosis. And then I apply the Winter's formula, that is 15 plus 5, that is 20, the expected value, and the actual value are matching in this case. So the answer in this case would be a partially compensated metabolic acidosis. I mean, obviously metabolic acidosis is what you have been able to answer, but because the Winter's formula is satisfied, so I will also write the word with compensated respiratory alkalosis. I mean, how did I derive that? I did it verbally because this is a revision class. We applied Winter's formula, and that expected that modified Winter's formula is 15 plus the value of bicarbonate given in the question. The value of bicarbonate is 5, so 15 plus 5 is 20, and that is matching with the actual PCO2. So because matching values are present, that is why compensation is occurring here. In the next question, all the three arrows are going up and up. So therefore, this is metabolic alkalosis, and again the compensation process is coming up because there is gonna be like Winter's formula getting satisfied once again. So this would be a compensatory respiratory acidosis. You just need to invert the data for compensation. I mean, M ka R kar do, acidosis ka alkalosis kar do, so that would never be a challenge. Okay. In 80, you can see that pH is less and PCO2 is elevated. That would mean that this would be respiratory acidosis in a patient. And because bicarbonate is rising in this case, so again it is partially compensated. That means there is a metabolic alkalosis component present. Arrows are going opposite. pH is more in PCO2. Ulta arrow chal raha hai na, to ulta arrow chalega, तो that means it's a respiratory problem. In respiratory problem, you don't need to even check out the value of bicarbonate, guys. Just check out the pH and answer here. I mean, even if you don't check out the bicarbonate value, chalega. Just check out the pH value and you have as a spotted answer in a question because the pH of the chap is elevated. So we will say respiratory alkalosis. So very straightforward one, guys. These are like super easy questions that would be usually asked to us, and you guys are doing a tremendous job with respect to answering them correctly. Then are causes of hagma and anagma. So I'll just jot them down. Hagma is cult. And Nagma would be Dr. Fuse. An all except question is usually asked on this. Even in NEET PG, they ask this. So K would be for ketoacidosis. U would be for uremia. L is for lactic acidosis, which could be due to drugs, which could be due to sepsis. And then T is for toxins. Toxins could be like ethylene glycol poisoning, methanol poisoning. Dr. Fuse, everybody knows, but we'll still practice it here. D would be for diarrhea. R is for renal tubular acidosis. F is for fistula, and then the use word is for that longish terminology, ureterosigmoidostomy. Quickly comment in the chat box what is the normal anion gap, and if you can type the formula, that is great. Otherwise, I'm anyway gonna write the formula. You can comment on the normal values there. The formula that you use is sodium minus the negative ions, that is chloride and bicarbonate. We do not take potassium in the final values. And when you're gonna utilize when you're gonna calculate this here, the normal values will turn out to be 6 to 12 milliequivalents. So yep, I think most guys were pretty spot on for this. Then is gonna be right middle zone pneumonia. The CRB score of the patient is 3. So I need to admit the patient. I mean, instead of curve 65, we can use a CRB score also. And usual cause of community acquired pneumonia happens to be pneumococcus. So he says, what is the best treatment that would be done in this particular case? Yes, guys, quick answers there. Piperacillin and tazobactam would be an answer for pseudomonas. No, I mean, if it is pseudomonas, that is where we are using piperacillin and tazobactam. No, the main management for these patients is respiratory fluoroquinolones, man. For routine community acquired pneumonia, what we will do is, if the curve score of the patient, suppose the curve score in this patient, if the CRB score in this patient was turning out to be 0 to 1, with 1 being age, then the answer would be given as amoxicillin with azithromycin. But if the curve score of the patient is 2 or 3, then in those circumstances, the drug that we use is respiratory fluoroquinolones. And the respiratory fluoroquinolones that we use on the patient is moxifloxacin or levofloxacin. This is a repeat question of your exam, guys. In the question, he did not, the CRB value was not given. He will make you calculate. No, C is for confusion, R is for respiratory rate. I'll write it here. You have to calculate. The question mentioned patient is having disorientation. The respiratory rate of the patient was given to be more than 30 per minute, and the blood pressure of the patient is less than 90/60. So person is going into a possible septic shock as well. So in those circumstances, the drug that we'll be using for the patient is respiratory fluoroquinolones. There are three drugs that we use: levofloxacin, moxifloxacin, and then is gemifloxacin. Levofloxacin, moxifloxacin, and gemifloxacin are the drugs that are used. So the correct answer for this particular question is option number A. And if this person was having a score of lower value, then it is amoxicillin with azithromycin that would be given. The main concept is like I'm getting varied answers for this question because the curve score is elevated. That is why patient will be given more aggressive antibiotics and hospitalization would be done into intensive care unit. The main concept is IV antibiotics have to be given. That is understandable. And those of you who have answered like vancomycin, then vancomycin is for staph aureus. And as far as peptaz is concerned, peptaz would be giving coverage for pseudomonas. Like suppose I was saying this patient is also intubated and there's a coverage required for pseudomonas, then peptaz would be answered. But then initially for management of any community acquired pneumonia, it is moxifloxacin or levofloxacin that would be given. My suggestion to you is just check out the curve 65 score part once again in either the main video or the rapid revision part. I think rapid revision would be more than sufficient. But yeah, because there were errors, so therefore it has to be practiced. Moving to the 85th concept for today. Yes, guys, leading cause of tension pneumothorax in a patient. There's like multiple degloving injury would not be the answer. That's like avulsion of the soft tissues as well. You have to select between the remaining options there. The leading cause for development of this would be yes. Very good. The correct answer for this would be barotrauma. The correct answer is option number A. Yes, it is not penetrating trauma, guys. It's a ventilator-induced trauma for tension pneumothorax. Then is a question on subcutaneous emphysema in a patient with hyperresonant percussion and distant breath sounds. The question is obviously on tension pneumothorax. Usually in this question, images may also be given, but there's a separate session that I'm conducting for image-based questions. So today I'm not focusing on images much and I'm focusing on hardcore theory. But yes, we do have a session lined up on image-based questions from PrepLadder. It's already being conducted. Some of the subjects are covered. Mine would be next month. So do check out that session as well, where images would be discussed because any exam about, I can say 15 to 20% questions are supported by images. So he says, what will we be using in this case of tension pneumothorax? I can expect answers from you guys here. Okay. I think most of the guys are managing to get this question correct because it is pneumothorax. We not do the thoracocentesis. Thoracocentesis is what is done for pleural effusion. Option number A cannot be the answer to this question because thoracocentesis is done for pleural effusion. Pleurodesis is done in patients who are having a lung cancer, so that is ruled out again. And then is wide bore needle aspiration, and then is wide bore needle thoracostomy. So we are not doing an aspiration, right? It's not that we are trying to suck out some air using a syringe and a needle. It is a wide bore needle thoracostomy. The correct answer is option number D. Exact replication of the question that came in the previous session, guys. It's not a wide bore aspiration. It is a wide bore needle thoracostomy. We just put a needle in the chest, right? And the air khud se nikalta hai na. I did not say that I'm trying to suck out the air using a syringe. So it is a wide bore needle thoracostomy that would be done for this case of tension pneumothorax. The site would remain the same, right? The site would remain the same. That is fifth intercostal space. Though there are a couple of guidelines saying second intercostal space only, but at the moment I'll not get into that. That controversy of fifth versus the second space. It is mainly that it is the fifth space in the triangle of safety where we'll put in the needle and then subsequently a chest tube would be deployed in this patient. So it is like a wide bore needle thoracostomy, and then we are gonna put in a chest tube. The chest tube would also be put in the triangle of safety. So I'm not going into the boundaries. I'll say them verbally only, like latissimus dorsi posteriorly, pectoralis major anteriorly, and then there's going to be fifth intercostal space. And after that, we will attach this to underwater seal drainage. So there are total of three things that are being done: wide bore needle thoracostomy, followed by a chest tube, followed by underwater seal drainage. Cool. Let's look at 87. Patient is having respiratory distress. The percussion note on the left side inframammary is dull with distant breath sounds. Because it is saying dull and there is distant breath sounds present, so I'm thinking in terms of a possibility of a pleural effusion. And he has helped me with the diagnosis saying chest x-ray shows blunting of the costophrenic angle. That means it's the pleural effusion only. And the pleural fluid protein is more than 0.5. The LDH values are elevated. The question is based on Light's criteria. And considering that there is Light's criteria, therefore the correct answer for this one would be exudate, and the only exudate among the four options which is present here is a parapneumonic effusion. All the other three conditions, congestive heart failure, cirrhosis, and nephrotic syndrome, are examples of transudative pleural effusion. Whereas when it comes to a parapneumonic effusion, it would be an exudative effusion. So yes, the correct answer for this one is option number A. Then they love to ask you regarding SAG, that is serum albumin ascites gradient, which is for evaluation of ascites. And patient is having ovarian cancer, and this ovarian cancer patient is having like metastasis to the peritoneal cavity, a peritoneal carcinomatosis. So you have to select for 88. What are the causes for what will happen to the SAG values in this particular case? Would it be like more than 1.1, or will the values be less than 1.1? Quick answers, A versus B, please. Remember this statement of mine, SAG value more than 1.1 is always for portal hypertension. Whenever he will give you a question on liver cirrhosis, whatever be the cause of cirrhosis, alcoholic or non-alcoholic, whenever he's going to give you a question on SAG value more than 1.1, it is always going to be cirrhosis. That is a transudative variety. But whenever he's going to give you for a cancer, therefore your answer would always be SAG value less than 1.1. And how to remember this would be a mnemonic by the name of TPN. TPN would be T would be TB, P is peritoneal carcinomatosis, nephrotic syndrome, and then is serositis due to autoimmune disorders. Autoimmune disorders can be like SLE, it can be rheumatoid arthritis. The main point is TPN is total parental nutrition, but today we are using it to remember TB, peritoneal carcinomatosis, and then for nephrotic syndrome due to autoimmune disorders. Yeah, Dr. Gitanjali, SAG values are always asked in the exam, so always a learning point, right? TPNS is a quick learning point for you. In 30 seconds, I can say that I made you remember SAG values, which are an integral component of any exam. In India, whenever they are talking, in OPD, you see pleural effusion ascites patients, so they give up questions on the same. So it doesn't matter, whatever is the type of exam, I think this would be useful. Yep, doctor, I think it should be useful. Worthwhile going through the concepts, quick revision, otherwise tends to become boring when we are reading the notes by ourselves. Okay, what is the investigation of choice for minimal pleural? Yes, guys, SAG and Light's criteria are always asked. Investigation of choice for a minimal pleural effusion would be an ultrasound. For a pericardial effusion would be an echocardiography, and for ascites again the answer would be given as an ultrasound only. The only point is values will change. Like for minimal pleural effusion, normal fluid is 5 to 15 ml, so anything more than that we'll be doing is an ultrasound chest, echocardiography, and an ultrasound abdomen. That would help us in identifying this. Okay, what is the preferred site for pericardiocentesis? Quick answers, please. Preferred site for pericardiocentesis. Your answer would be given as Ziphisternal. We will be using a Ziphisternal approach. We will not be using any intercostal approach, but a Ziphisternal approach for pericardiocentesis. It would be echocardiographic guided. Can I have the answer for abdominal paracentesis? Thoracocentesis, I know everybody answers 8th intercostal space, so that is not an issue. As low as possible. And I'm writing the remaining answer also. That would be usually lateral 2. Or it is midway between the mid axillary, it is midway between the posterior axillary line and the scapular line. It would not be incorporating the mid axillary line. The needle space is not gonna be mid axillary. It is midway between the posterior axillary and the scapular line. We stand behind the patient and then we are doing this procedure. Yes, guys, I did not get an answer for paracentesis. Yes, guys, quickly, paracentesis, uska tummy mein pani bhara hua hai, so you need to remove, like if I draw like this, he's having like fluid, right? This is linea alba, this is groin area, pelvis area, rectus abdominis muscle. What is the preferred site? Very good. You'll go 2 inches below the umbilicus of this patient, 2 centimeter, 1 inch, or 1 inch is 2.5 centimeter below the umbilicus. So the preferred site for going ahead with paracentesis would be subumbilical. Or the second site can be from the anterior superior iliac spine. We can be putting a needle about 1 inch above and little medially, that is like in the flanks of the patient. So there are two sites that I mentioned. One is going to be flanks and second is going to be subumbilical. Between the two, the single best answer would be given as subumbilical for abdominal paracentesis. Needless to say, they've asked like what blood vessels can be damaged here. So the blood vessel that is damaged here is the inferior epigastric artery. Somebody commented in the chat box also that inferior epigastric artery, and it is intercostal artery that would be damaged in thoracocentesis, and inferior epigastric artery that would be affected in this particular patient. Left or right quadrant, left would be preferred, as you can see, as compared to right. I could have put a cross on the right also, but then I put a cross on the left to say that it is the left quadrant that would be recommended to avoid the damage to the cecum. Okay, again a very standard question of your paper. Patient is having bronchoria, purulent bronchoria, which is changing with posture. Like when he's bending forward, more bulgum is coming, and there's digital clubbing in the patient also. Like a paratypic appearance of the nails is present in the guy. So there is a suppurative lung disease that is happening. Yes, guys, is it lung abscess or is it bronchiectasis or is it chronic bronchitis? Options are chronic bronchitis, then is gonna be bronchiectasis, and then is going to be lung abscess. So the answer would be given as bronchiectasis in this case. This is the same condition in which the chest x-ray as well as the HRCT will be showing a presence of a tram track appearance. There are meaning of the word bronchiectasis would be destruction and dilation of the large airways. That's why like the purulent bronchoria component is present, and it has like a postural component to it. But if I change the question and says patient is having purulent bronchoria with distal clubbing and the chest x-ray is showing an air fluid level, then air fluid level means that there is like an area where the pus will settle down due to gravity and there would be air on the top. So in those circumstances, yeah, signet ring is another hint for presence of bronchiectasis where the airways would get dilated as big as the blood vessels. But if there's an air fluid level present, then I'll change my answer to that of lung abscess. So two questions on purulent bronchoria have been asked and they're like one-liners, very straightforward ones. If they gives you a air fluid level with purulent bronchoria, think in lung abscess. If it's gonna be bronchoria with changes in posture, distal clubbing, and if he gives tram track, then cool. But still, even without that, we can be answering this. Yeah, clubbing we don't get in COPD, guys. We don't get clubbing in COPD. So bronchoria would be present in chronic bronchitis also, but digital clubbing is not present in chronic bronchitis. That's the main point that would be used for differentiation. Yeah, clindamycin would be used in this case for lung abscess. Then is the leading cause of acute viral hepatitis A, B, C, D, E? Yes, guys, clindamycin is the correct answer here. Yes, if it is anaerobic, yeah. Yes, the leading cause for viral hepatitis would be given as hepatitis E. It is not hepatitis A. Hepatitis A is for children. Hepatitis E is the leading cause. This is what Harrison says. Acute viral hepatitis is hepatitis E. Okay, so moving ahead, yes, what is the most common cause of what is, I think there's some numbering issues, but anyway, what is the most common cause of liver transplantation among the following? Alcoholic cirrhosis, non-alcoholic fatty liver disease, and hepatitis C. Yup, guys. No, hepatitis C is the viral cause. Now, overall, the most common cause now is fatty liver, is basically non-alcoholic fatty liver disease. The overall most common cause of liver transplantation now is fatty liver. I mean, there's a silent epidemic happening in India now. 35% of Indians are having fatty liver. Most of us know, like we keep on eating those momos and that ghatiya mayonnaise that comes with it. So that is trans fats only that goes inside our body, and that results in, or we, those paranthas, no, that Gautam Nagar paranthas that are made with that poor quality oil, they are gonna contribute to fatty liver in people. Biliary atresia, doctor, biliary atresia is the cause of obstructive jaundice. You know, if a question is regarding obstructive jaundice and he says like what is the cause of obstructive jaundice in a neonate, the leading cause, then answer is given as biliary atresia, for which we go ahead and we will be doing is a HIDA scan and then a Kasai procedure. But yeah, it is alcoholic earlier and now it is non-alcoholic fatty liver disease. Okay, what is the antibody? NAFLD, doctor, NAFLD. Antibody in primary biliary cirrhosis, where there is a fibrosis inside the liver. The antibody is by the name of AMA. The AMA would stand for anti-mitochondrial antibody. Very good, guys. I mean, you getting very good answers there. If he talks about antibody which is present in primary sclerosing cholangitis, This antibody is present in ulcerative colitis also. That would be ulcerative colitis is P ANCA. And yeah, quickly comment on the drug of choice for ulcerative colitis and drug of choice for Crohn's disease also. So can I have answers for the same? P ANCA is a good input coming up. Tell me the drug of choice for ulcerative colitis. Yes, guys, drug of choice for ulcerative colitis. Yeah, ulcerative colitis, nowadays the answer would be given not as sulfasalazine. I would recommend you to answer this as mesalamine over sulfasalazine. I mean, sulfasalazine has been used for generations altogether, but then the side effect profile of this is not very favorable. So I'm not even writing it at the moment. I just want that memory of yours to be slightly erased and changed it to mesalamine as compared to sulfasalazine. And for Crohn's disease, guys, can I have the answer, please? For Crohn's disease, yes. Yes, Crohn's, somebody has mentioned very rightly, it is budesonide that would be used. This would be a budesonide ileal release preparation. It is a budesonide ileal release preparation, and then we can go ahead with like biologicals in these patients like infliximab or golimumab that can be used. But then initially it is the following drugs, mesalamine, budesonide, that would be used for management of these patients. Okay, great. Next one is a patient who's having surface antigen positive and IgM class of antibody to the core antigen. This would be answered as acute viral hepatitis. That would be hepatitis B. And if it is surface antigen positive and IgG class of antibody, then it would be chronic viral hepatitis B present. Let me know the drug of choice for chronic hepatitis B. Acute usually will be self-resolving. You don't need antiviral drugs, but for chronic hepatitis B, the drug that would be used would be. Yeah, the last one is vaccination. That is understandable that everything is negative, but the person is having anti-HBs present. That would be vaccination. Yeah, we can be using tenofovir or it can be entecavir. Either of the two can be used for management. We can use PCR for monitoring the response to treatment in the patient. What is the drug of choice for hepatitis C and D? It is not plus. It is not plus. It is either of the two. It is tenofovir or entecavir. The combination is for hepatitis C. Yes, for hepatitis C, it is sofosbuvir, and along with sofosbuvir, the second molecule is velpatasvir. Good. And hepatitis D, the answer would be given as alpha interferon. Okay, fine. Investigation choice for Wilson disease, guys. And which basal ganglia is affected in Wilson? Investigation choice for Wilson disease. Ceruloplasmin would not be the investigational choice, right? That's the screening test. The investigational choice would be answered by you as liver biopsy with estimation of hepatic copper content. The investigational choices liver biopsy with estimation of hepatic copper content. The second answer, if liver biopsy is not given, would be PCR, and this PCR would be done for ATP7B gene. There are two answers here. One is liver biopsy, second is PCR for ATP7B gene. If the question is changed over to screening test for this condition, that is when we will be talking about urinary copper and serum ceruloplasmin. Actually, the problem is ceruloplasmin can be low in multiple other conditions. That is the reason why, apart from serum ceruloplasmin, we can be doing is a 24-hour urinary copper. And yes, the basal ganglia which is affected in this condition is the lenticular nucleus. So this would be like the workup of patients of Wilson disease. Plus, we get that very classical giant face of panda appearance on a MRI head in this patient, which is because the damage to the basal ganglia, mainly the midbrain and the basal ganglia, are the one that are affected. It's the lenticular nucleus that gets affected there. The chelating agent that we use for this condition, the first line drug that we use for this condition, the chelator agent of choice would be given as trientine. And the deciding the need for liver transplantation, we use an index that is called as Naser's index, which helps us decide the need for liver transplantation in these patients. Okay, so moving to screening test for scleroderma. Quick answers there. Antibodies that we are using Screening test for scleroderma, investigation of choice for scleroderma. In fact, the investigation of choice we have discussed already, that is topoisomerase. There was a woman who was having pulmonary artery hypertension, and we had taken care of a pulmonary artery hypertension using ambrisentan or bosentan. Screening test for this condition would be answered as anti-nuclear antibody only, ANA only. Yes. Then is entry level criteria for SLE, that is anti-nuclear antibody ANA. Anti-Ro antibody is to be answered for two situations. One is the photosensitivity that you can encounter in patients of SLE, that is one. And second can be, values more than 1/80 are okay. Then the second one is that this can contribute to development of a neonatal presentation. The neonatal presentation can be development of complete heart block because the antibody will damage the AV node of this baby, and that is why that complete heart block as a manifestation can occur. Anti-ribosomal P is for neuropsychiatric manifestations. The usual neuropsychiatric manifestations that are asked would be, one is depression and second is psychosis. But this is very peculiar because neuropsychiatric profile with an antibody is what he wants to hear. The antibody name is anti-ribosomal P antibody. The most specific test for diagnosis of this condition is anti-Smith antibody. The most common presentation was again asked, I think, in the recent NEET exam. So you guys can comment there: photosensitivity, joint pain, and one we can take as lupus nephritis. Select one: photosensitivity, joint pain, and lupus nephritis. What is the commonest presentation in this case? The answer would be given as yes, joint pain. Yep, it is arthritis, it is joint pain, musculoskeletal complaints. The most common presentation of SLE should not be answered as lupus nephritis is characteristic. That's like having the highest. When you look at the scoring pattern, it's given 10 points. Lupus nephritis has the highest rating from the clinical diagnosis perspective, but then the commonest presentation happens to be joint involvement. As far as the leading cause of death is concerned, slightly controversial, but Harrison says kidney damage, lupus nephritis, and then he says after 45 years of age, it is cardiovascular mortality and the heart involvement could be responsible for this. And the kidney biopsy finding of lupus nephritis would be that of wire loop lesions. There are grades also that you read. You also read about like the various types of lupus nephritis. There, stage 4 is one that is the most common one that you read in pathology, but wire loop is like one of the commonest ones that is read. Okay, guys, so it's almost been 2 hours that we've been trying to do these concepts. I've tried to be a little faster, trying to focus on, those questions. Thumbprint and then full house effect would be present. That's a good one. That this wire loop lesion would be having a full house effect. The full house effect would be immunofluorescence and thumbprint would be on electron microscopy. Cool. And then what is the best test for diagnosis of dermatomyositis and S. Sjogren? Why I've included these two is because here the antibody is not diagnostic. It is gonna be like a biopsy based test. Like for dermatomyositis, the main test would be MRI guided muscle biopsy. Very good. Though you can be having in some cases anti-Ro antibody, but that's not very specific. So it's like MRI guided muscle biopsy as the best one. And then would be for S. Sjogren syndrome. Yes, S. Sjogren would be having that dry eyes, dry mouth, and dry vagina because the Bartholin glands are also involved. So in this, perifascicular muscle atrophy can be present. But then for S. Sjogren syndrome, it is dry eyes, dry mouth, and dry vagina. As I said, yes, guys, what is the best test for diagnosis? Yes. Your answer would be lip biopsy. It is a labial biopsy that will be doing, or a lip biopsy that would be done. That will be showing the damage in the minor salivary glands of the patient. So what I've tried to do in this would be to focus on those like core aspects which are like, which have to be answered very fast because they are going to be like the basic foundation of generating your score. Out of 30 odd questions that usually come from medicine, 30 to 35 approximately, I expect you to get a strike rate of at least 25 questions correct. Out of these, 15 will be very easy one, and the remaining 10 that are present are the ones where you'll have to apply a bit of logic, exclusion. So not all questions would be direct, some would be having logic, some would be direct questions only. So it is just that if you just focus on the core aspects that I've described at the moment before you, the differences, the fundamental aspects that we have discussed at this particular point of time, the PDF would be available in the app itself, so you can just scroll through it and listen to it at maybe a faster speed if you want subsequently, or it will come up in the Telegram groups anyway. So one of them is mine, obviously. So if you can join there. So yep, guys, thank you so much, and we'll be seeing you again. I mean, the image-based session is scheduled for the next session of mine. That's where the ECG component will be discussed. So all the tachyarrhythmias and bradyarrhythmias I am keeping them reserved for like that very intense focus. Will do like 1 hour intense study for all the top possibilities of tachy and bradyarrhythmias here. But at the moment, I've tried to focus on like the core aspects which are asked, where the theory part is important. I mean, I want you to get those 15 to 18 correct from like those 13 from those fact-based questions, and then subsequently the analytical capabilities. So you need to get to the target, guys. I mean, I can say that these 2 hours or like 120 minutes are like worth the effort that we have put, and we'll be back with much more such rapid fire sessions. So stay focused. PrepLadder's got your back, and I've got your back. I can say like that. And yep, guys, see you once again. Thank you so much. Yes, doctor, you can go through it for NEET PG as well. The basic data remains the same. No, I mean, it's only analytical capabilities and the negative marking that kills in a NEET PG. And for FMG, they have the luxury of answering all the queries. So thank you so much, guys. Okay, Dr. Rani Thoy, thank you so much. Ajay, take care. God bless you. And it was really nice interacting with you. I really love the talent that you guys are having. I mean, if I take myself two decades ago, we never had, I mean, so much of knowledge, right? And you guys are like bursting with so much of information thanks to all these apps that are available. So bye-bye, guys, and take care. Okay, take care, guys. Bye-bye.